Today's Health and Adult Care Scrutiny Committee meeting. It's 2nd of December. I've a reminder that the meeting is being live streamed, and we may also be dealing with the item 11, which is the integrated care system, earlier due to NHS officer availability, depending on how the meeting goes from a time perspective. So if I could just start with apologies, and also with our members, saying hello to our members who are online. I can't actually see them on this screen, so I'll ask Fred to go through that, please.
Yeah, thank you. So in terms of apologies, we've got Councillor Hodson, Tildesley, Huckway and Gent have sent their apologies. And then we have Councillors Youssef and Granger and Morgan online.
Thank you, Fred. So item number 3, declarations of interest. Members should please declare interest either now or before discussions take place on the relevant item. Any declarations of interest? Councillor Ketchin.
I work in the NHS, just a bit of a standing thing.
Thank you. Anybody else wants to declare anything? No. Okay. And sorry, if I could just go back to make one further announcements under chair announcements. I'd like to thank Amy Howard and Nikki Mahoney for organising an excellent visit to meet with Devon County Council's hospital discharge team. I was really impressed with the team. It was a very informative event. I'd like to thank the members of the committee who came with me, and Councillor Keeling as well. And I'm going to ask for a report on the work of the discharge team and the challenges that are faced for our next meeting. And in our January meeting, we'll also have a note from our visit. So if I could just say that, thank you. So if we could now move, please, to minutes of the meeting held on the 14th of July 2025 and the special meeting on the 22nd of September. They've been previously circulated. I don't know if anybody has any comments. No, so I shall sign them as a true record. Thank you. After the meeting. And I believe that I can't see him on the screen in front of me, but I think Peter Hay may have just joined our meeting. So welcome, Peter, our specialist advisor. Moving on to item 5, items requiring urgent attention. I don't have any. Item number 6, public participation. There's none today that I'm aware of. And now if we could please move on to the matters for consideration or review. Item number 7 is overview and update on adult safeguarding. We have a report from the Director of Integrated Adult Social Care, and I don't know whether our Cabinet member would like to introduce this report. Thank you, Councillor Keeling.
Thank you, Chair. Can I first thank Tandra Foster and her staff for this report and other reports that I will be introducing. In this report, for the update of the Integrated Adult Social Care, I draw your attention to the strategic plan within that. The safeguarding approach outlined in this report is firmly embedded within the Council's overreaching strategic priorities. It supports independence and dignity by fulfilling statutory duties under the Care Act 2014, ensuring that personalised care enables individuals to live independently for as long as possible, while safeguarding those unable to protect themselves. The commitment to stronger communities and safer places is reflected through the harm reduction initiatives, community safety measures, and robust multi-agency collaboration, particularly via the Torbay and Devon Safeguarding Adult Partnership and its governance framework. Continuous service improvements remains a core focus within the quality assurance mechanism, such as practice quality reviews and feedback loops, driving high standards and value for money services. The centralisation of the Devon Safeguarding Adult Service further enhances workflow efficiencies and decision-making quality. Although the report primarily addresses adult safeguarding, it emphasises on trauma-informed practice, including approaches and training for elected members, contributes to safer environments for all, including children and young people, and reinforcing the strategic priority of early intervention. Finally, governance and accountability are strengthened through clear internal structures, including the Safeguarding Governance Group and transparent reporting lines, ensuring strong leadership and responsible decision-making. Collectively, these measures demonstrate a comprehensive, personal-centred safeguarding approach aligned with the Council's vision for safety, inclusion and continuous improvement. Chair, myself and the Director and her staff are available for any questions.
Thank you very much, Councillor Keeling. Members. Who would like to ask a question or make a comment? Councillor Julian.
Yeah, thank you, Chair. Yes, it all sounds very good, but as long as we can stick to whoever takes a case on, the vulnerable case, and they're not moved from pillar to post. So somebody, like, they take a case and then they phone up or something happens to them, and then, so, oh, sorry, we haven't got that person, we've got somebody else. And that's when things get lost and then things don't happen. So I think that, if you don't mind, Chair, we've got to sort of get away from people being moved from pillar to post. We need to have somebody that is going to stick with that person. And if they can't stick with them, as long as they've got somebody to back up, so say they couldn't make it or on holiday, you've got somebody else, rather than, oh, I don't know your case, don't know this, don't. And you hear it over and over again, Chair. It is, you know, they're vulnerable, they get lost, and then everything goes pear-shaped. So if we could really, if we're going down this road, we do need to be on top of the case. Thank you, Chair.
Thanks, Councillor Julian. Sarah?
If I can respond to that, thank you. I'm Sarah Macrath, Head of Quality Performance and Redesign. We're very fortunate in adult social care in that we have a relatively low turnover of our social workers and other key staff in delivering our operational service. That's quite different to some other local authorities. We've got quite a stable workforce, and I think the risks that you've outlined, while they're real, you know, if there is a transition from one worker to another, there is a risk of vital intelligence being lost, but we're relatively protected against that. The way that we organise our adult safeguarding service is that we have the decision making dealt with by the Devon Safeguarding Adult Service. The inquiry work does then pass out to one of our community or county teams for the more detailed inquiry work. But that's undertaken by a team who are based out in the locality. They have good relationships with our multi-agency partners. So I think there's a good rationale for having the decision about, is this a safeguarding concern, taken in one place, but the work then passes out to the locality community team where people are generally well known and well supported in their communities. So I recognise it's a risk. I guess what I'm reassuring is that we've been quite thoughtful about that approach, and we do have a relatively low turnover of staff out in our community teams to ensure there's some continuity of service.
Very reassuring. Well, I hope that sticks with that, because that sounds good for Devon, doesn't it? That if other counties are not so good as us, I'm tickety-boo with that. I mean, if we can keep that together, amazing. Thank you.
Can I follow on from that, please? Because the report identifies that there are 4 contractors, agency workers, that are going to be addressing the backlog and the triaging. So that's slightly inconsistent, I think, with the idea that somebody is that there's a very stable team. And I would just ask that what's the sustainability plan for when those contracts come to an end? Thank you.
So that's a good question. Thank you. We've put some additional investment, some additional resource into the Devon Safeguarding Adult Service in order to get over a backlog of concerns that are waiting for that Section 42(1) decision. What we believe, and we've modelled according to the sort of data and analysis, is that if we are able to deal with the backlog, our core team is sufficient to deal with the oncoming demand and flow of work. So if we can just get over the backlog, we have the right sized safeguarding team to deal with the kind of process flow that is usually presented to us. I don't know if that kind of answers your question.
It does, but we aren't meeting our target at the moment, are we? In triaging in 85 to 90% of cases.
That's correct. Yes, that hence the additional investment, which will we hope, and we've modelled on the basis of the modelling, we believe that will give us the resource to achieve the 2-day target by the end of January, early next year.
Thank you. Members. Councillor Dawson.
I think Councillor Rogers was first, if he wants to go first. Sorry.
I didn't see your hand, Councillor Rogers.
Thank you, Chair. I want to thank hardworking officers for all your work. I attended with other members the Youth Council meeting last Saturday, and one of the concerns they raised, if you're going from childhood to adulthood, they need reassurance what plan is in place within Devon, because we heard some pretty awful examples where they've just fallen off a cliff. So I welcome, I think it's on an agenda for a forward meeting, but within your report, do you identify the amount of individuals who are on child safeguarding who are going to become an adult within a calendar year? And do we have that confidence that they're going to be picked up?
So that is a piece of work that we're starting to do between the Devon Safeguarding Adult Partnership and the Children's Safeguarding Partnership. There's a different legislation framework that applies to child protection as opposed to adult safeguarding. And we're doing a further piece of work just to check that those arrangements work well together and that people don't miss out or fall off the cliff edge as you've described, Councillor Rogers. So it is a piece of work that we're focusing on.
And we make sure we communicate to the Youth Council that piece of work. Obviously, there's a load of detail in that piece of work, but we owe it to the Youth Council to advise we're listening to their concerns.
Yes.
Thank you. Councillor Dawson.
Thank you. I guess it has already been brought up about the triage things and about the response time. And I just wanted to draw everyone's attention to 3.2.4. And I think the chair's already mentioned about 85 to 90% of the time not meeting that sort of 2-day response target. The longest wait currently is 53 days. I'm struggling to understand that in safeguarding, whether it's neglect, whatever it is. Is it, obviously we can't have individual information, but is that person all right? Like for 53 days is quite a significant wait, which could, I'm a registered nurse, that's a life or death. That 53 days for safeguarding concerns is quite significant. So I just kind of wanted to talk a bit about that, please.
Yes, so we do have a risk screen at the point that the concern is received, and the more urgent risks will be dealt with within the 2-day timescale. So the most urgent risks will be dealt with within the 10 to 15% of concerns that we address within 2 days. It's not ideal to have somebody waiting for kind of 53 days currently, and we do have the additional investment to bring that wait time down. What I would say is that it's reflected elsewhere in the report that some 23% of concerns go forward to a safeguarding inquiry. So we would say, yes, the threshold there is met. We need to look into this in more detail. Conversely, that means that 77% of cases don't go forward to a safeguarding inquiry. So the person may have some needs, or there may be some issues to address, or it may simply be that another agency has reported a concern that actually there isn't any real kind of substance to. So I guess what I would want to offer the committee some assurance is that the high risk issues are dealt with first when they come in, and there is a fairly significant volume of safeguarding concerns that actually don't go forward to an inquiry, but we may deal with through another route.
Thank you. And I wanted to follow up with a question. We had the masterclass, which was great and really informative, particularly understanding about our statutory obligations about safeguarding, and that even if there are mental health struggles associated and Devon Partnership Trust take that on, we still maintain that overall responsibility for making sure that's dealt with. I just wanted to know about the impact of some issues that have come from the CQC about concerns of safety within Devon Partnership Trust, highlighted at Langdon Hospital, and there've had to be some measures put in. How do we work with that if we're working with an organisation where there's highlighted then some areas where safeguarding is failing, or there have been other failings, and I don't know too much about it, so I won't be going into the biggest amount of detail, but how do we manage that responsibility if we're using another agent who are experts but are then also highlighted to have failings when it comes to safety, please?
Yes, again, very good question. What we've reflected in the report is that when an inquiry is caused out to another agency to deal with on our behalf, we do retain the statutory responsibility for that inquiry as Devon County Council, and our Devon Safeguarding Adult Service retains it as a piece of open work. They will only complete the piece of work once they've had assurance from the agency carrying out the safeguarding inquiry that all of the objectives have been met, that risk has been reduced, that we've achieved the outcomes that are important for the person. When there is a systemic failing, so a question about whether an organisation has failed to discharge its duties responsibly under safeguarding, then we would maintain a high level of oversight of that work with our team managers within the Devon Safeguarding Adult Service retaining active contact with the agency throughout that.
Thank you. Thanks very much. Thank you, Chair.
Can I just follow that up with a comment, please? Because I understand the principles about causing out, but what the report doesn't show me is the extent to which our duties as the retaining authority for those safeguarding responsibilities are being hampered or being unable to complete them because of any fault or problems with our partners who we've caused out to. So I don't know whether you can comment on the extent to which that is a problem for Devon County Council.
I guess, I mean, I'm not aware of any detail of the inquiry that our colleague was kind of referring to. I'm not aware of any issues with our oversight of the caused out inquiries. We have good working relationships through the Torbay and Devon Safeguarding Adult Partnership. So that partnership acts as the partnership board acts as a strong force for bringing all partners to the table and to be able to offer check and challenge on each other's work within the partnership.
Thank you. Councillor Davis.
So we've established that it's roughly around about 75% of inquiries that don't go forward, referrals that don't go forward to an inquiry. If those people who are the case in the inquiry, if they do, something happens in their life and it spirals out of control a few months later, and they then do come back in as an inquiry and it does go on to be an investigation, do you have a mechanism for collecting data to tell us that at one stage they were a referral?
Yes, so we do monitor the number of repeat concerns that come through on the same individual. So we're closely sighted on whether a concern has been addressed as an inquiry, in the first instance, and whether that same person is referred back in at a later point.
Okay, that's good. Thank you.
Councillor Ketchen. Thank you, Sue.
It's a question about the metric of this 40-hour assessment and your view on, do you think it's a useful metric? And if you don't, I mean, well, I'll start with my view because I can't help but always giving my opinion on things, even if I don't have all the facts. And a metric where a sort of a high functioning organisation, got a lot of regard for DCC, given what it achieves with the money it's got. But a metric that's got a 15% hit rate is a metric that has some problems with it, not necessarily what's been achieved. How can we, what's your view on this metric? And is there, I presume it's a statutory expectation reporting it, and is there perhaps a sub-metric to be reported in it so that we can actually get our teeth into the the performance here of perhaps the true emergency safeguarding assessments that need to be made within 40 hours versus the people who've got more chronic needs that are perhaps more complex and that perhaps need a little bit more time to unravel to support. So if you follow the split, I'll just clarify, what do you think of the metric, and is there a case to have a sub-metric of true emergency safeguarding concerns?
Good question. I mean, it isn't a statutory metric, so it isn't a metric that's set within the Care Act or the supporting guidance. It is a metric that's been set by the Torbay and Devon Safeguarding Adult Partnership. We have to have a metric, I think, for dealing with concerns as they come through. It is a challenging metric. I think it is the right place for us to challenge ourselves, because we do need to be confident that we are addressing all of those issues in a timely manner, even if a fairly high proportion of them don't go forward to inquiry. We still need to have an early look at it. I think it would be worth us exploring whether there's a kind of sub-metric for the high risk cases, because we would want to be absolutely confident and to be able to assure you that those were being addressed within the two-day timescale. I have to say, you know, it's a challenging metric, but it is a common one that is set by Safeguarding Adult Partnerships and by other local authorities. So it would be quite difficult, I think, for us to step away from that measure. Our focus needs to be on achieving a higher proportion of safeguarding concerns being looked at within the two-day timescale.
Can I just follow up on that then? I mean, we've got a 15% hit rate, and I'm not a big fan of metrics, I've got to be honest, in the context of this. But, you know, if we're going to have a metric and you don't want to step away from it, and unless we're going to have some kind of other measure of what is a true emergency, are you going to hold yourself to some bar that says this is a good standard of achievement? Otherwise, the metric is meaningless. And you know, you can see where I'm going with this, and I think you've sort of said it yourself, you know, earlier about we've had a masterclass on it as well. You know, the 15%'s a meaningless figure, because I don't think it at all reflects the quality of care that's given here. And I think we need to have some kind of either measure that we hold ourselves to as the gold standard, or we have some other way of measuring what we're trying to achieve here. Otherwise, it's just not helping scrutiny.
Yes, I don't disagree. I think 15% is not helpful in terms of the performance against that measure. We are aspiring to be achieving that measure by the end of January with the additional investment that we've got. That may not necessarily be a kind of easy journey to achieve within that kind of timescale. Just, I guess, for your assurance, there are other measures that are equally valid. So we have a practice quality review process. We look at the quality of the decisions that are made within our Devon Safeguarding Adult Service. And I think our metrics in relation to that indicate that something like 85% of the decisions are of a satisfactory or excellent standard. So, you know, it's not the only metric. I agree, when we're not achieving it, it isn't necessarily a helpful metric, but it does sit amongst a range of other measures that evidence the quality and the safety of the work that we undertake.
And my understanding is it's kind of a widely accepted 2 days to triage, and it is really important that it's done quickly, isn't it? Because obviously speed is absolutely key in cases where people are potentially at significant risk of harm. And so what I'm not clear on is whether harm has been our residents have been experiencing harm because we're failing to meet that 2-day target in 85 to 90% of cases.
So I would say we don't have any evidence of harm having been achieved. We do target the high risk cases, you know, as they come in. Those are the cases that we address first, and we ensure that those go through to further inquiry work as quickly as possible and within the 2-day target. So I think the cases that tend to wait are the ones with an initial view of being a lower level of risk and a lower level of harm to the person.
Thank you. I'm not sure who was first, whether it was Councillor McGough.
Thank you very much, Chair. Councillor Ketchin has actually raised most of the question I wanted to raise there, so it only leaves me with the time a little bit left. Page 5, it states if through 2023-2025, conversion measured on a rolling 12-month basis ranged from 17 to 90% since April. However, the rolling 12-month conversion rate has been steadily rising. In September has risen by 23%. Is there a reason why it's risen so much? And work on the back of that question, how closely do we work with Torbay, and how much influence does Torbay have over Devon? I know we're supposed to be working joint together, but is the president set for Torbay? The reason I raise this, obviously Torbay's got less residents than what we have in Devon, so I didn't want to we're trying to prioritise Torbay over Devon, because obviously Devon has less residents to deal with quickly.
So
does that make sense?
It does kind of make sense. I think we have the Torbay and Devon Safeguarding Adult Partnership arrangement because that makes sense for us. We share similar providers, many of the same providers to our colleagues in Torbay, many of the other agencies. So Devon Partnership Trust provide a service across the whole footprint, and it helps us to learn from each other and work together. Having said that, there is a complete separation between the service offered to Devon residents and the service offered by Torbay Council to Torbay residents. But it's an opportunity for us to work together and learn and share information. Our conversion rate has gone up. I think the principal reason for that is that we've consolidated 3 separate safeguarding hubs into the Devon Safeguarding Adult Service. That's given us better oversight of the work of that team of people. It's given us a better opportunity to do some practice improvement work within the safeguarding hub, and as a result of that, we're achieving a more consistent standard of practice, and that's what's driven up the increase of conversion from concerns to inquiries.
Thank you very much. The point I just wanted to raise there was the fact that Torbay obviously is dealt with different council. Is that prioritised through Devon's money? Because obviously we're the biggest precept earner, and I just don't want to see that Torbay are basically getting the higher standard what we're getting as Devon. Because I feel at the moment from reading this paper, the figures are helpful if you want to look at figures really, but you know, to me residents aren't figures, but it's the only way you can explain it properly to us without numbers coming into this case. But I just want to make sure we definitely prioritise the residents of Devon, because I feel at the moment we're kind of at a dodgy ground.
Our focus is on the residents of Devon, and that is our total priority. I think, I mean, I don't know what more I can say than that. We work closely with Torbay, so we share learning with each other, but our focus as Devon County Council is on the residents of Devon, not the residents of Torbay. And we ensure that while we learn from Torbay and we share the same providers, that our focus is on improving practice for the residents of Devon. And our resources are entirely focused on Devon. Yes. Yes. We're not subsidising Torbay to any extent, shape or form.
Can I thank you. Can I bring in Tandra, who's online? Thank you.
Thank you very much, Chair, and thanks for agreeing for me to work from home, so hopefully reducing the chances of me spreading any bugs. Just on the point of our partnership work with Torbay, it is just in relation to the partnership board. So what it has allowed us to do is share an independent chair, but it's also quite helpful in terms of benchmarking. But we have a completely independent and separate safeguarding function, which is solely focused on DCC residents. So I just want to assure councillors that by sharing a board doesn't mean that we've diluted what we're doing. We are totally focused on it, but as you can see in the report, we are on a journey and we are seeking to improve further, but it's not as a result of partnership with Torbay.
Thank you, Tandra. Could I just bring in Donna Manson, please?
Hi, thank you, Councillor McGuff. I think it's a really important point you make, because resource and investment results in more staff to carry out tasks or to deliver things in a more timely way. And you've heard today that we've put more investment into this area. I think it's important though to state that in terms of the overall envelope we get in partnership with the NHS in Devon is less than the national average, and we have the lowest investment in the South West. So I think you make a very valid point, and I think it's important that that's noted. that we need to work to understand what the investment is with a key partner for our adults population, because safeguarding is a multi-agency joint responsibility, and we need to bring forward to this committee those different levels of investment and ask questions so that we get equal investment to other organisations.
Thank you. Can I just ask Donna about the Adult Safeguarding Board? Obviously, we're the lead agency, and we've got every year we have the report from the annual the Adult Safeguarding Board. But can I ask you, what do we do as an authority to assure ourselves of the effectiveness of the board? Thank you.
I think the answer lies in the structure. If we could go into the structural chart, and I don't know if you've got that, put that up, but there's a structural chart that outlines what that procedure is, what that process is. Also how the DAS and the DCS and myself look at that with our performance directorate, and also the meetings that the DAS and myself have with the chair, with Paul Northcote, in terms of annual meetings. But I think in response, I'm just looking at Tandra, the best way to show that is a structural chart that shows what that looks like, because that means there is a structure to it, there is a governance to it. There's also a lot of learning that we do as part of that whole structure at every level that comes up and then feeds back into training across the partnership.
Thank you. Oh, Tandra.
Sorry, thank you. So just to support what Donna said, we can supply a chart after the meeting, but there are regular meetings with the independent chair to go through how it's going. Also for him to give us feedback, because ultimately the role of the independent chair is to hold all of the partners to account. We agree what the annual plan will be, so it's a sort of a mixed process. But what occurred to me was that that's how we do things in Devon, and I'd be really interested to understand how it works elsewhere. What I'm used to in the other authorities that I've worked in is a similar approach. So regular meetings with the independent chair, regular meetings with the DAS and the chief exec and the independent chair, and it's sort of a mixture of us testing them and how well they're running the board. For example, the backlog of safeguarding adult reviews that they went through post-COVID as an example of where we've done some effective working, but it's also the role of the chair to hold up the mirror to us as well. But if there are other suggestions of things that might be helpful, clearly the opportunity for the chair to come here and face questions is another opportunity for yourselves in Scrutiny to ask him some questions as well.
Thank you. Yes, I'm expecting Paul to come to our meeting in January, but I don't know whether Peter Hay, our advisor, wants to comment.
Grant, I think what you've done very well as a council is look at adult safeguarding through a number of lenses, if that makes sense. And this is part of the consideration you're giving it. So Tandra today has given you good details on how the council is meeting its duties as a council, including where that performance needs to be improved. You've got the opportunity when the chair comes to look at what the multi-agency kind of context is. And again, to, I think, ask how that can be developed, and particularly how that can give you some kind of assurance about, for example, the check and challenge between agencies on issues about, are they care concerns? Are they safeguarding? Those kind of issues you were just toying with in relation to health providers. And also, I think, some reflection from Paul as the independent chair about what his ambitions are, for example, to improve effectiveness of relationships with housing. And then I think what you've just alluded to is an important corporate piece which sits around all of this, which is how does the council meet its lead agency responsibilities for the effectiveness of the system? And you've just had a pretty good account of the way in which that's met. And I think if you pull all of those together, Tandra's just said about kind of comparing with others, knowing what good looks like. What we do know is that CQC, and I know you haven't finished CQC yet, so this feels a bit unfair, but we do know that it's already saying that CQC's assessment is that safeguarding has scored low, even in higher performing councils. So it's an area I think that needs real attention. in anybody's improvement plan before CQC2 starts the revisit process. And I think the answer lies in thinking about those three buckets, if that makes sense. And you've made considerable progress in making those visible. So I think it's about continuing, if you like, this journey and adding into it, in particular, I think, into the multi-agency space, some of the issues about how you work on a qualitative basis about the multi-agency working, and that might pick up things like continuity that was raised to the first point, some of this check and challenge around care concern, safeguarding between partners, so on and so forth. So you're beginning to do that. But I think you've really got the structure of that. And what do they say? Fine bones. I think you've got the bones right, if that makes sense. And it's now beginning to think about, as a committee with the officers, how you work together on that improvement agenda.
Thank you very much, Peter. Members? Oh, Councillor Dawson.
Sorry, I just had two other little thoughts really as we were discussing. I guess just an acknowledgement really that sometimes cases can be more complex than initially thought. I have discovered in my professional life sometimes the most simple things turn out to be the most complex ones, and I guess that keeps niggling me when we have cases that are kind of lingering for 53 days, or and I know that's the longest. So I guess I'm just mindful actually that that's acknowledged, that sometimes you scratch the surface and there's a whole other complex problem. There could be more serious risks behind that. And I guess I also wanted just to touch on asking the team what they feel about the public perception about safeguarding thresholds, and whether they feel that that's moved, whether it's more difficult to hit that kind of threshold to become a fully sort of supported concern that goes forward, and if that has moved, why has it moved? I'd just be really interested, just because that's something I hear from the public quite often, is that they feel that it's more difficult to hit that sort of that kind of criteria, I guess, at which it becomes a formal concern and then gets support.
Okay, I mean, I kind of recognise your concern about, things that appear simple often are more complex underneath it, and scratch the surface and you find out more. So I absolutely kind of share that view and that perspective. In relation to the question of the threshold, has it become more difficult for members of the public to hit it? I think what we probably tend to see is that if we have a broad publicity campaign around adult safeguarding, and that might include communications to the public, but also to our partner agencies, we tend to see an increase in activity following that campaign, and then it kind of tails off again. I think we are some way from having had a similar campaign. So we're probably at the sort of tail end of public awareness, if I can kind of phrase it in that way. I think in order to be able to sort of do that again, what we would want to be confident is that we're within sight of the 2-day target. We're not going to generate a lot more work than we're, able to sort of process in a timely manner. So I think it's an issue that needs a bit more careful thought about how we might promote and try and raise public awareness about safeguarding again.
Thank you. Thanks very much. And I think, yeah, you're absolutely right, aren't you? We want everybody to be safe, but actually we also need to be able to manage what comes in. And I guess, although campaigns will also pick up issues that, where people have perhaps fallen through the cracks, as it were, it will also pick up all those people that have had lifelong concerns about Johnny down the road who lives in this house and wears wellies all year round, or, whatever it is, where they don't know the background and things like that. So it might be very simple inquiries. Thanks very much.
Thank you. Councillor Rogers.
Thank you, Chair. My question is about, we have a registered doctors' strike planned for the 17th December for 5 days, and then we're into Christmas. How confident you have continuity plans to deal with that strike action and Christmas? Based on the targets you have, will the 5-day hospital strike and Christmas affect performance?
Okay for me to come in, Chair. Thanks. Hi, it's Amy Howard, Deputy Director responsible for operations. So it's not unusual to have kind of certain events that cause disruption and needing to look at continuity plans, you know, across health and social care. Just heading into the winter, we're kind of very well versed in working across partnerships to understand the impact that that would have and how we work together. So all of the assistant directors that work to me are kind of jointly working with our health colleagues and linked in with the acute hospitals as well. So local contingency plans will be already being put in place in relation to the possible impact that any strike action might have in relation to hospital support and flow. And as a key partner across health and social care systems, we'll work together with our NHS partners to try and understand how we can support any contingency measures that might be needed. So local plans generally happen across each of the areas in Devon, linked in with the local NHS partners around that.
How is that going to be communicated to patients? Because patients are key in all of this. And obviously, if you're a patient in need and you've got issues, then communication is key.
Yeah, so we really pride ourselves on over 17 years of great integrated working relationships in Devon. So the way we work on the boots on the ground with our health partners, and whilst our medical professionals are absolutely vital to the whole kind of health and social care system, we will continue to have a variety of social workers, social care assistants, nurses, physiotherapists, occupational therapists, all working out in communities with GP practices as well. So part of the way that the contingency plans get put into place are being able to communicate with people who we're going in and seeing regularly on a day-to-day basis. We've got, I think so they can quote, but I think it's like 27,000 social care workers out in our communities working with residents day in, day out. So how we use those local communication networks to flag any risks or concerns. Also, that bit about triaging is really important. So we'll use our own expertise and skill from the various multi-professionals and multi-agencies that work together to really escalate back into the acute system if we feel like there's a particular risk or need for an individual. So we're always doing that triaging and prioritising work with our local partners too. So just part of the whole ecosystem, I suppose, of how health and social care try and work together for any form of kind of resilience planning that we need to do.
Thank you, Councillor Ketchin.
Just picking up on Councillor Rogers' concerns, the Devon County Council doesn't have any doctors in its staff. It's got lots of carers and lots of community care in particular, and obviously feeds into service design. But junior doctors on strike will not mean nurses, OTs, physios, community carers on strike. It will be junior doctors or resident doctors, as they're now called. And senior doctors will have to uplift the gap in the emergency care services that are required to be covered. And it's not really the remit of Devon County Council to necessarily comment on that, I would argue. But we do have governors that are on the acute hospital trusts, and we could refer questions to them about how those are going to impact services. But emergency services and acute services will be covered. It will be people on waiting lists that are potentially going to be impacted.
Thank you. If I could just pick up one more point on the report, and that's around the pie chart on page 8, which shows the outcomes of identified risks. So it's shown that risk remains in 15% of cases and risk reduced in 51% of cases. In terms of the risk remains, I calculate that that's around 200 people. And the text says this is usually on the basis of individual person's choice. Do we have any data around where it's not on the basis of the individual's choice and the demographic of the people within this group?
So I don't have that data immediately to hand, but it is data that we would have available, and I can sort of provide some supplementary information after the report about that identifies where either the person lacks capacity, so cannot choose to remain at risk, or whether we're simply not able to kind of remove or reduce the risk. And it isn't a question of the person choosing to live with that risk.
Thank you. Does anybody else? Oh, Councillor Abbott.
Thank you. Mine's about the process within the committee, really. On the recommendations that we're presumably moving towards, then I have no problem with A. With B, are we to consider at this committee now how to develop the programme with visits and so on, or is that something that takes place offline afterwards?
Thank you, Councillor Abbott. I would think that would take place offline afterwards, but I would actually like to add a further recommendation because I don't know what the committee feels, but I feel that at the moment we've only got we're only meeting our 2-day target in 85. Sorry, we're not meeting it in 85 to 90% of cases. And so I think that we should be calling for a further report within the next 6 months, where the service is aiming to get to the 2-day target within by the end of January. And I think we should ask for a further report covering any points that remain outstanding and our targets within 6 months to see where we get to, so that not only have we hopefully hit that target, but also that it's not just a kind of hit it 1 month and then not the next month, but that we it's a sustained target, and that we've got the capacity to make sure that we are, because it's obviously absolutely key. So I don't know what the committee feels. I can see, I think Councillor Abbott's hand went up first.
Yes, but I'm not talking to your point. I was talking to my own. I'll come back to you when you're ready.
Thank you. Councillor Dawson.
If the committee's, if that's the committee's desire, would argue strongly for a sub-analysis then to understand really why the outliers that continue are agreeable, because I think our masterclass suggested yesterday that will be the case. So we need to understand who needs to, what level of people need to be hitting the 2-day target, so we really understand what we're measuring here. And I would encourage that and support your suggestions so that we can understand that, but not just the metric as it stands, a sub-analysis, so we can really get an understanding of what we are measuring.
Thank you. That sounds fine. Thank you. Councillor Dawson.
Yeah, I was going to say what Councillor Kitchen said when he spoke for me when you called me to talk. Sorry. I'd say, yeah, I think that the other issue about having subcategories and understanding that data a bit better is also about public confidence as well, because 85 to 90% of missing that target doesn't look great, even if there's stuff that's in process, and even if we understand underneath that actually there are other cases that wouldn't need a 2-day sort of turnaround in reacting to that concern. So I think that also needs to come back as well, so that the public can be reassured that there are some times when a 2-day response actually wouldn't need to be the target, because it's a different kind of concern. Thank you.
Thank you. So I continue with process. On recommendation 1.1c, to ensure attendance at any member training opportunities. I'm not quite sure whether the word ensure is what obligation can be imposed, but encourage might be more useful. And on D, I'm not sure that it should only be all members of the committee that are able to implement a safeguarding concern, but it should be all councillors, and so there should be an outworking from us to the whole body.
Thank you. That's absolutely fine with me to change it, ensure to encourage, and I think that we have tried to include all members across the council in our masterclass, but and we can certainly recirculate because we've got a recording of it, haven't we? We can certainly recirculate that and emphasise to everybody's personal responsibility for adult safeguarding, as well as the corporate responsibility for safeguarding. So I'm very happy to support the continued effort to try and include everybody. Thank you. Councillor Julian.
Yes, if you're proposing that, Chair, I second it, so I'd be quite happy with that. Thank you.
Tandra.
Thank you, Chair. Just in relation to that point D, I think we probably need to think about what else are we going to do. So I'm not sure everybody can get to a masterclass, and I'm not sure it works for everybody in terms of how they take on board information. So we're looking at some other ideas, including a sort of informal lunchtime discussion with councillors where you've got particular cases that you might be interested in, and it might help unpack the sort of understanding of what we mean by safeguarding, and then how we might be able to help you, because there are sort of prevention responsibilities, which is something that it's or Safeguarding Board is supporting all partners with. So how do we reach out to people who don't quite meet the threshold, but absolutely there's something going on with some multi-agency discussion? We might be able to help that person avoid coming into safeguarding altogether. So I just wanted to sort of suggest that you don't have to, I'm not suggesting anything for point D, but I just wanted to flag that we've also been giving some thought to what else can we do to really embed safeguarding in both informal as well as formal ways.
Thank you, Chandra. I think we'd all really welcome that. I think, you know, the distinction between kind of the more narrow responsibilities under the Care Act and the more general safeguarding obligations is a really would be really helpful for people. And I think also, you know, as well as encouraging people to watch the masterclass, having a kind of face-to-face, if people can come along, would be, it's sometimes much easier, isn't it, just to have a kind of like a lunchtime discussion. So I think we'd all welcome that. Thank you. So, oh, sorry, does Councillor Granger, is that just a, oh, we've seen your declaration, thank you. So I think if we could just move just to those recommendations with the slight tweaks from Councillor Abbott, and then also that we'll have a request to report back within 6 months covering the points that we've talked about. If we could go to a vote on that, is that okay? Thank you very much. So if we could move on, please, to agenda item 8, which is the report from on compliments and complaints and customer feedback. And I think we have Councillor Keeling to introduce the report before we move to Helen Wyatt. Thank you.
Thank you very much, Chair. Excuse me, the Adult Social Care Customer Feedback Report 2024-25. If I could say that Devon's integrated adult social care supports around 11,500 people at any time, and 20,000 annually. With national data ranking the council among the top performers for satisfaction, independence and care quality. Complaints remain low at under 1% of the population served, while compliments, particularly for social care enablement, highlighted staff's professionalism and compassion. Key challenges identified include recurring issues in care quality, communications and financial clarity, with Ombudsman investigations showing an 83% uphold rate. Improvement actions focused on better data insights, enhanced feedback systems, and proactive engagement ensures services remain responsive, inclusive, and personal-centred. These findings reinforce the Council's commitment to continued improvement, transparency, and high standards of care. Colleagues, within the strategic plan, you will see in 6.1, the production of an annual report on customer feedback supports the strategic priority number 3, continuous improvement of services. 6.2 is openness and transparency, sharing ideas and listening to feedback through genuine partnership and better engagement will help focus on improve the services that matter the most. 6.3 is 2 of the 6 commitments in strategic priorities. 3 stand out. Strive to provide excellent frontline services that are responsive to residents' needs, and the drive consistently change and transformation across all our services to maximise value and achieve outstanding standards of service. Overall feedback demonstrates the significant impact of adult social care services and the importance of maintaining high standards of empathy, professionalism and accountability. Insights gained will inform future service development, ensuring care remains responsive, inclusive and empowering for all. Chair, myself and the Director and staff are happy to answer any further questions.
Thank you. Councillor Rogers.
Thank you, Chair. We should absolutely celebrate the success and the great care we as a corporate organisation place on people. Of the people who've complained, have we gone back to them and are we confident they're happy that we've resolved and learned from their complaints?
Would you like me to answer that, Chair?
Yes, please.
Thank you. So we, just to confirm, I'm the customer relations manager, so have responsibility for overseeing the complaints process. To introduce myself. So to answer your question, Councillor Rogers, we don't go back to check if a complainant is satisfied directly. That we wouldn't have a capacity at the moment to do that with the number of complaints that the council manages across all services. But they do have the ability to come back and ask questions or to go to the Ombudsman if they are unhappy with the response to their complaint.
Thank you. Councillor Dawson.
Thank you. I guess first of all, I just wanted to be reminded, what is the expected time frame for responding to a complaint?
Helen?
Would you? There isn't one standard time frame, so the complaint regulations allow it to be reflective of the specific complaint. We tend to suggest a 20 working day response time, but that will be different for every case depending on the complexity, and that will be confirmed to the complainant.
Thank you. So I'll just continue with my question then, Chair, if that's okay. I'm looking at 6.3, overview of complaint responses. Timely responses to complaints remain an area for improvement. In 22, 23, 53% of complaints responded to within the expected time frame. And I think that's quite difficult if we don't know what that expected time frame is specifically, if that seems to be a movable feast depending on how complex it is, which I absolutely understand. And I guess I'm just kind of looking at that table from 2018 through to 24 to 25 that's below 6.3, and just looking at 65%, 72% dropping down to 50%. I was wondering if we could explore that a little bit really about why that seems to be sort of heading downwards really, what's behind that and what, is it that different approaches are needed? Is it that there's more coming in, there's more complexity to complaints? Just wanted to find out a bit more, please.
Thank you. And as part of that, I would say that there's been a real reduction in timeliness in 23, 20 in Q3 to 4 of 24/5. And maybe you could comment on that as well, please, Helen.
Well, I certainly can give a high-level response, but it may be that possibly one of the adult social care colleagues would like to come in as well. So I don't think there's going to be one answer I can give you to say this is the reason why timescales are as they are. You've rightly highlighted that they remain a challenge. I do accept it's difficult for you to assess against timescales if you don't know what they are, but they will be different in every single case because the regulations allow for, as I said in the report, allow for those timescales to be reflective of the needs of each case. We would expect managers responsible for responding to complaints to let us know as a central team if there are challenges to them, so we can keep the complainant updated. that is often part of the issue, that they have a lot of day-to-day challenges in their role that they're dealing with, as you've already discussed in detail, safeguarding matters perhaps that will take priority. And sometimes, unfortunately, that means that my team isn't necessarily informed if there is a need for the timescale to be extended, so we're unable to inform the complainant. So I think that is one of the issues, is around communication, capacity challenges perhaps, but I do wonder if one of the my adult social care colleagues might want to also comment from their perspective.
Thanks, Helen. Amy speaking. Yeah, so I think it's multifaceted. I suppose the important bit about that, the time frame, is that that is a time frame agreed with the complainant. So, for example, if a complaint comes in, if it's reasonable to try and turn that round within the 20 days, that will be communicated to the complainant. And then if for whatever reason we haven't been able to operationally get to it within the 20 days, then that's when it becomes a delay. However, if as by day 10, we were to say, actually, there's quite a lot of complication to this complaint. It involves a number of different officers that need to kind of input into it. Can we extend that with you and with agreement from the complainant to a kind of 30-day response? Then that would be recorded as on time. So it is a bit of a nuance in terms of how the complaint process does work. We also do build a quality check into our complaint response as well. So we do know that that means it does often take a little bit more time, because the officer most involved with the person will try and provide the information for the response. And then to ensure that's kind of quality checked, that then goes to a team manager or a service manager as well. So I think we do recognise that there are points in our current process where we could be looking to improve that, to try and make it easier to ensure that we have the right communication back with the complaints team to keep the complainant up to date and informed, to get those metrics right for the timeliness of complaints. But certainly we do always try and start those conversations with resolving a complaint at the earliest opportunity. And sometimes just picking up the phone and having a conversation is the most kind of meaningful part of the complaint response. And then the formal written response thereafter sometimes takes a little bit of time. And I think our processes don't always allow us to be as slick as we would want to be in that too. So that's certainly an area that we continue to look at how we can improve.
Thank you. And I guess, am I right thinking, because you're working with different partners and different providers and things like that, that actually that might also add an extra layer to as well, to get them to kind of pull into responses to, that might also cause a delay, I guess.
Yeah, quite often nobody's case is kind of just a simple, straightforward one response. It might be our partner agencies that we're working with. It might be other parts of the council as well, in terms of coordinated responses with children's services, our client financial services. So where our financial assessments are done are through our finance department too. So often that requires a couple of officers to get together to formulate the response. So I think that, you know, getting a good quality response is really important to us, and then ensuring that's quality checked as well. So I think all of those things do make the metrics of kind of reporting on complaints a little bit multifaceted.
Thank you. I hear what you say, Amy, but you know, the response, the timeliness response has frankly plummeted in 24-25 from 77% in Q1 to 45% in both Q3 and Q4. So what assurance can you give the committee that the timeliness will improve from the adult? I mean, there's other departments sometimes involved, but from an adult services perspective, what assurance can you give this committee that that timeliness will improve? When's it going to improve by? And because I'm concerned not only that it's unsatisfactory to have complaints are not dealt with in a timely way, but that in itself then generates more complaints. So what assurance can you give this committee, please?
You okay for me to come in, Tandra? Yeah. So I think that it's about ensuring we get the right performance and reporting governance structures within adults as a directorate too. So we can certainly make sure that we take an action away today to ensure that this the reporting that we get here is triangulated against those performance boards that we have internally operationally. I think that's where, if I give the example of the Safeguarding Governance Board, where we're kind of holding to account the data that you've seen in the safeguarding report today, I think that there's more work we can do as a directorate to ensure the same for the complaint response data that we're seeing as well. So an action for me to take away will be to start looking at this within our adults SLT, senior leadership team, reporting under finance and performance, so that we can triangulate that and then look at how we can improve. I think part of the work that we're doing around our overall adults improvement will enable us to improve on that position as well. So some of this, I think, is led into a process, so kind of how we can improve the process and be more efficient in the way that we're reporting back with the complaints team too. So Helen, I think you've got your hand up, and perhaps getting you into that space and working with the teams as well to refresh and remind everybody about the complaints process and responses could improve that metrics.
Can I ask Helen, how much is the timeliness, the decline in timeliness as a result of the fact you're not getting the answers or the responses from the adult services?
I'm sorry, could you just repeat your question?
Yeah, so
Apologies.
when you're dealing with complaints, you deal centrally with the complaints, and you then have to go to the managers and ask them to respond to the complaint. Is the majority, I mean, obviously you have pressures within your team, and I understand that, but how much is the delay in responding in a timely way to complaints because you're not getting the information that your team needs to actually complete that work? Just roughly 50%, 80%? Are you able?
I couldn't put a figure on that, I don't think, without doing some analysis. It certainly is a challenge for us, but that is not isolated to adult social care. Just to, I don't know whether that is an assurance or not, but it's a challenge organisationally for every service, is being able to prioritise responding to complaints. It's unfortunate, but it's the reality we're currently faced with, I believe.
Thank you. Donna?
I'd just like to point out to members here that if you look at the volume of the people that we work with, we've got a statistic that 0.9% of the population served annually complain. We've already heard earlier today that we're in the top quartile for customer feedback, 0.9%. I'd be interested in what that is benchmarked nationally. So I think there's maybe something in that area. And I think the other bit is we've got how you look at this as overall context. We've got more compliments than we got complaints. I certainly see all the serious complaints and the high level complaints that come through, and as was alluded to by Councillor Dawson earlier, they're very, very complex. They involve multi service areas, from legal to often our connectivity with other partners and providing services for families. So I think there's an important context that perhaps needs to be considered here. I also need to highlight that we've been quite clear in adult social care in terms of the budget we receive nationally, and also what I've pointed out in terms of the South West having one of the lowest partnership funding from the NHS nationally, that, this is a service area that's had to reduce its cost by over £60 million in the last 2 years. And we're going into a budget where we're expecting overall another £30 million to be taken out of services in Devon from the national funding that we receive. So I think there's an important context here, because I do think there is an issue here where year upon year we need to make reductions in the number of staff that we've got. We need to prioritise our services, and it is a serious complex issue. And I'm going to be honest, as head of paid service, is I see far too many staff working beyond their hours to deal with what comes in every day, and not enough resource to actually address these issues. So it's all a bigger context, but I think we need to be honest about what actual staff we have in place to do the jobs that are needing done. Putting all that together, in summary, and I look forward to response in the inspection, I actually think the staff are doing a good job in exceptionally challenging circumstances. But I think if we are going to respond to committee in this way, we need to see that in the round in terms of what resource we have, what volumes coming in. And also, I think it would be helpful, we've got an independent advisor here to find out about that benchmarking, because I think if you're to look at businesses and look at the volume of what's in this paper, then a less than 1% complaint rate, but a higher level of compliment rate, I'm sure a lot of businesses would be thinking that's a good outcome, but I'm quite happy for us to be challenged to do better. But I think we've got to be honest about the context we're working within. And I say that as we are very concerned about trying to unpack the budget settlement for Devon in the next 3 years as part of the spending review, and the implications that will have in terms of the resources that we have.
Thank you, Tanja.
So thank you. I suppose timeliness is really important, and Donna's right, we get a small number of complaints, and I think we should be proud of the fact that we get more compliments. But that said, if you're making the complaint, you want it responded to. We do have detailed breakdowns. So one thing Helen's service does provide, because I'm copied in and I use it to help encourage people to respond, is a full breakdown. There's usually a small proportion that have tipped over in terms of the timeliness, but the vast majority that I see on the sheet are being dealt with, and it is for a variety of reasons. So sometimes it's the QA function, sometimes it's just trying to get responses, information from somewhere else, but we can bring you to a future session. I know you're really interested in this, a breakdown of what we get the most complaints about, if you like, and what the levels of complexity are, and we can talk to you about the timeliness. I think the key for us is always to learn from the complaints. So some of the information in the complaints report talks about the themes, and I think that's what's really crucial. So we absolutely need to have a timely response to the complaint, but if we're seeing a theme, then we need to get to the root cause of why people are complaining, and maybe more than one person's complaining. So you'll know that these reports come to my performance board, and you'll know that we use them to help drive improvement. So we can bring other information to future scrutinies, but timeliness is important, but it's also the theme. So what is the learning and what are we doing about it? That I think also we need to be focused on.
Thank you, Tanja. I didn't see Councillor Rogers and then Councillor Dawson.
Thank you, Chair. Helen, how are your staff feeling? It can't be easy dealing with day after day, complaint after complaint, albeit it's a small minority. How do your staff feel, and what can we do to help your staff at the coalface?
I would say my staff have developed, perhaps you could describe, quite a thick skin over the years. We've got fairly low turnover, although we're not a huge team, and many of the team have been around for a number of years, and so you do get used to it. But that said, it is a challenge. We do see some of the worst of the worst, and we need to remember sometimes that is the situation, and as has been talked about, we're only seeing a very small proportion of what's going on. So I think we've got a good team spirit. We have to do everything with a little bit of humour, despite the fact we're dealing with difficult subjects. But so what can you do as a committee? I suppose it is just about helping hold people to account. It certainly it makes everybody's lives easier if complaints are responded to swiftly. Complainants are happier. They may not be completely satisfied, but they may be happier if we're able to respond more quickly. So I think that's probably where your role comes in, is around the accountability piece, and continuing to ask the important questions.
Thank you, Councillor Dawson.
Thank you. I just wanted to end my input with a bit of a celebratory question, really. We've seen some amazing feedback here, like really empowering people, listening to people, life-changing work, really, that we're seeing across the board. what are we doing with those? Those compliments are really powerful. They can help shape things. They can help us to retain staff. So how do we use those compliments to I guess, create more resilience and to have a more sort of empowered, positive and I don't know, hopeful staff team, please?
Donna?
I think strategically in the people survey, I mean, it's really important saying Helen and our team, they experience trauma every day. Everything that's coming in of serious complaints are real trauma situations. And I know that from what Helen and the team, they say they're kind of, you know, they toughen up to it, but these are people's lives and there is compassion for people's lives and wanting to do a better job. And I see that in the cases that come through and the ambition to do it better. So we're not stepping off that, but actually it is dealing with what's happening in people's lives, and it is. So I think there's one thing for us to consider at strategic level about how we support. We do a lot in children's area, and in people services, but we've got a number of enabling services in the council where a trauma-informed approach and a supportive approach, I think, is absolutely critical. In some service areas, staff experience supervision, and a meeting with many of the managers, whether it's highways officers or customer response. They're dealing with vulnerable adults every day. For example, at our operations centre, when vulnerable adults are in distress, we often work with the police to support adults. So I think that broader recognition that adult services is everybody's business in the council, and you're hearing today that it does touch upon the customer team as much as it does the staff and adult social care. So I think that's something to think about. What are we doing about it strategically then as part of the people strategy? We are focused this year on how we celebrate success. I know I've been in examples where adult social care celebrate shout outs and thank yous and have all sorts of staff boards. So we've been collecting compliments from staff about what staff do, but I think that bigger bit of celebrating success, we would welcome any ideas from yourself, because it is a balance of being compassionate, being supported, being ambitious, but also recognising that success, because for people like Helen's team, not very often it's really difficult stuff, and only a tiny bit of the day is that kind of positive opportunity. But that's not to say we don't want to hear it. So I'm glad you've raised it today, because actually we do want to be here for families. So thank you.
Tandra?
So I suppose a couple of things. So Helen sits in the corporate centre, but whenever we do extended meetings, conferences, Helen or reps from her team are included as part of that. So we very much work as a single team and give that mutual support, which I'm hoping is appreciated. In terms of where we get compliments in, so anything from I love seeing it when somebody comes in and says something wonderful that a team member has done, and I'll want to go back and say, that's brilliant, I really love that, it really made my day. But we have the big thank you, we put out things in our newsletter. I know Sove and Amy have their own catch-up meetings. We do a lot of face-to-face sessions with staff, so we really take as many opportunities as possible to celebrate when things are going well, because obviously you want to market, but you also want to build on it as well. So encourage people to listen to what that person's done. So we do use it. As Donna says, if there's more ideas that you have that you think we benefit from, always interested in that. But we absolutely, when we get compliments or positive, we recognise staff and we make sure that our whole directorate understands, and possibly beyond.
Thank you. If I could just thank you for the responses on that. I think also there's perhaps some space as well to do more with celebrating that with the public as well, to work on that confidence in adult social care and the delivery across Devon, because again, like the headlines are all that all these services are failing across the UK, and actually we need to be celebrating and getting that public confidence up. And I guess also the more we celebrate that empowerment and the compassion of staff and things. The more we celebrate that, the more we attract people when it comes to recruitment. And the more we encourage other people to celebrate and to get in touch and to say, oh, I had a really good service too. Yeah, so I'd really like to see that as well going forward. Thank you.
Thank you. I've just got one question, if I could, for, well, I suppose it's for Helen, and that's around the quality and diversity, that we've got new forms, I think, or refreshed forms, and only 18% of the complaints have that section completed. And I'm wondering what we can do so that we understand the complaints and whether they're coming from any particular sector or area, what we could do to improve that, please, Helen.
Certainly. So at the moment, we do rely on complainant self-reporting, and many of them choose not to. They're all invited to, but many of them, as you've seen, choose not to provide us with that information. We don't have any intelligence from that process as to why they don't want to, because they're not answering the question. We are restricted currently around GDPR in, whilst my team has access to the adult social care case management system, we can't extract the diversity, equality related information from that system, as complainants won't know we're doing that. So that's, I think it would be fair to say it's an ongoing conversation with adult social care colleagues about how we can tackle that particular point. Without wishing to put somebody on the spot, I think Sarah Macareth, you were very interested in this point before, whether you had some thoughts to share as well, because I don't know if I can fully answer Councillor Bailey's question here.
Thank you, Helen. Sarah.
It is an area that we should explore further. I think in my earlier attempts to get somewhere with it, we were somewhat frustrated by the inability of the customer relations team to identify the right information according to people, but I think we need to pursue a different solution to that. So I'm happy to follow it up with you outside the meeting, Helen.
Okay.
Thank you, Maria.
Just on that point, I'd say we encourage people to fill out the data, but we can't compel. So it's just really how we can work and encourage people to do exactly that. We have an equalities team and we have the support available, but we really are, it's encouragement rather than being able to compel. And I think that's where the difficulties and the frustration arises.
But if you could continue to try and, Sarah, thanks. Any further comments, or shall we move to recommendations? I think one of the recommendations I would like to include that isn't here is around the timeliness of the annual report. So this report is 24-25, year ended 31st of March 25, and it was, I think it's dated August 25. So I'd really like this committee to see the report for 25-26 closer to the end of 25-26. So I know it might not be possible to complete it within the first week of April, obviously, but to have a report that comes forward earlier in the cycle than this one, so it's completed earlier, because the more time lag there is between the end of the year and when we get the report, I think the less effective we are. So it's important. So if we could have a recommendation, please, that we ask that the annual complaints, the annual compliments and complaints report is completed as soon as possible after the end of 25-26 and brought forward at the earliest opportunity to this committee. I think that would be a welcome addition. Councillor Julian.
Yes, if you're proposing it, I'd like to second it, so we'll move
you.
it forward. Thank you.
Thank you. So if I don't know whether anybody else has any suggestions, but I'd really like to thank Helen and her team, because I think it must be very challenging dealing with well, certainly the complaints. So thank you very much for all your hard work, for your report, and for coming along today. We've got our recommendations. We note the progress in response, we call for the annual complaints and compliments report to come forward as soon as possible after the end of this financial year 25-26. And I think that we very much continue to explore, as per recommendation B, how we can provide further insight and involvement into the complaints and compliments process. I think it is a really, really invaluable tool. I will be meeting with Helen regularly because I'm concerned that if there's a particular complaint that comes through to her that we need to have oversight of. So I think we need to continue that engagement process so that we're fully sighted on the complaints and compliments that come in. And I also think it's really important that we try and explore what more we can do to elevate the compliments. And I totally take on board Councillor Dawson's comment about the compliments and celebrating the successes, because there is amazing work going on within this council and we need to publicise it as much as possible and work with Tandra and the service to do that. So I don't know whether anybody has any comments or we can just move to vote on that. Should we go to a vote? Thank you. Thank you very much. Thank you. So if we could we're just going to take a 2-minute break, and then we're going to, I think the NHS will be available. Is that correct? At 12 o'clock, if that's okay, because they're only available at 12 o'clock. Would that be okay? So if we could just pause for a minute, thank you. Hello, if we could reconvene, please. So we're moving now to agenda item 11, which is the Devon ICS Finance Update and Health and Care Strategy. And I would like to welcome Libby Ryan Davis, Deputy CEO and Chief Strategic Commissioning and Planning Officer at NHS Devon, and Kirsty Denwood, Interim Chief Financial Officer at NHS Devon, and both Libby and Kirsty are joining us online. Thank you. So we have your report. Thank you very much. And would you like to make any introductory comments, please?
Yes, thank you. If I can just make a couple of points in introducing the health and care strategy. And then I'll hand to Kirsty, who's just going to pull out some key points on the NHS Devon financial positions and savings requirements. So some of the colleagues present today will know that we've recently completed some masterclass sessions with the overview and scrutiny committees on our NHS Devon health and care strategy. Our health and care strategy was developed over the summer, and our NHS Devon board approved our health and care strategy at its meeting in October. The strategy is setting out really Devon's NHS response to the 10-year health plan for England, which has a real focus on three key shifts. One being from hospital to community, where care will be delivered and available much closer to people's homes and where they live, and moving more towards a very local neighbourhood health model. A shift from analogue to digital, which is really looking at how new technology can liberate staff from admin and also allow people to manage their care much more easily, in the same way as we would all recognise that we would shop or bank online. And then from sickness to prevention, so a real focus on, as well as managing illness when that's required, being able to reach patients much early in their health journey, and supporting them to make healthy choices as much as possible. So the development of our strategy has been a real key moment for the NHS in Devon. It is the first time that we have a really clear strategy for the NHS as a commissioner in Devon. So it sets out our clear vision and priorities. It meets our statutory duties, improves the accountability and transparency. We are a very challenged system in terms of the NHS in Devon, and Kirsty's obviously going to talk from a financial perspective. But this strategy is very much about that shift to prevention and really driving that focus on keeping people well and healthy closer to home. And ultimately supports the long-term stability and sustainability of the NHS in Devon. So I'll hand to Kirsty just to cover a few areas before we open to questions. Thank you.
Thanks, Libby, and hello all. I'll just pull out the salient points. I assume people have read the finance report, but just pick up on the main areas. So the financial plan for the Devon system for this year is a high risk plan, and it was known to be high risk right from the outset. We required 53 million additional funding, deficit support funding, in order to achieve the break-even plan that we were required to deliver. So this was provided nationally. It is contingent on delivering our plan, so that deficit support funding is at risk if we don't actually deliver the plan that's behind it. It's required us to do 256 million SIP, so cost improvement plans or savings plans, depending how you like to call them. But this is the largest ever SIP that we've had to do as a system. I think the prior year was about 213 million. So again, it's a big increase and a really challenging area. And that's where the main risk lies in the plan, is around the delivery of the SIP. So we did have quite high risk at the beginning of the year. We have brought that down, but there's still unmitigated risk within the plan. And as a consequence of that, individual organisations have taken recovery action. So UHP, so Derriford, have got a financial recovery process and a financial recovery board. RDUH have now got a turnaround director appointed to help with their financial recovery, and Torbay were receiving recovery support from the national team as part of some intensive support that they qualified for. We're also a bit behind on the delivery of SIP in terms of whether it's recurrent or non-recurrent, and this has affected our underlying position, so our run rate of expenditure as we leave the year, which then manifests into a problem in the next financial year. So that's something that we're also having to tackle as well. The cash regime has changed this year, so access to cash is a lot more limited than it has been previously. However, where we have been experienced cash issues, we've put in cash requests and they have been approved. So we do have a process and a confidence that we'll get the cash required to deliver the plan. The other area which was quite a high risk was workforce reductions. So a big element of the savings plans, particularly in RDUH, was around workforce delivery. A lot of that workforce was, I believe, in the corporate services area. But as there's been no access to funding for redundancies, it's been really hard to take those costs out and to take the staff out. There have been schemes offered like MARS, a mutually agreed resignation scheme, but the take-up's been a lot lower than anticipated. So getting the workforce numbers down where required has been a bit of a challenge as well. So they're probably the key elements. There's obviously more detail in the report, so I'm happy to pick up if there's any specific questions.
Thank you. To me, the situation at NHS Devon looks quite dire. I mean, isn't it? Would you describe it as dire?
It's very challenging. I'd put it in that category, yep.
Because what really concerns me, and I'm sure it concerns the committee, is that both trusts may be unable to make timely supplier payments and consequently would face a range of operational difficulties. What does that actually mean for the people of Devon?
So this is where for the cash regime, that if you can't take all of the cost out that you need to, then you're going to run out of cash to pay for everything. But there is now a process been agreed. It was very late coming out to us from NHS England where we can apply for cash. So they have agreed that there is a set number of working days operating cash that's required by all organisations, and they will support the cash drawdown for that. So that risk is now starting to go away because we've got applications in for cash and some of those have now been approved. So that is, before we didn't have the protocol from NHS England. It was very delayed in being issued because they hadn't told us how we're supposed to manage shortfalls in cash. But we've now had that, so we've got confidence around the cash delivery, which means we can pay the suppliers. We will be able to pay the payroll, and that's what the worry was around the cash flow. But that is a risk that now we've got quite a sound mitigation for.
Thank you. Committee, questions for Kirsty and Libby? Councillor Rogers?
What keeps you awake at night, and what are you doing to mitigate the risk locally and within Devon, and where are the risk areas of the 3 hospitals? Where's your biggest risk in terms of turnover issues? If operations presents themselves, are you neglecting on care?
So it's quite a lot of questions in that. Yeah, I mean, I can pick out from where the greatest financial risk is. So I think the greatest financial risk is with the Royal Devon and Exeter Hospital, which is why they've got a turnaround director in, and that's because they've not been able to deliver the SIP because they've not been able to reduce the workforce, but they've also had some other challenges in taking cost out. So I think that's where the biggest financial risk is. So we do have a system finance recovery programme, where as a system we are trying to manage that risk and improve that position. There's quite a lot of focus on that at our board and in our committees, and as a group of all of the chief execs and CFOs who meet weekly to manage that challenge. We've also been working with regional colleagues on what we're doing to support RDUH in delivering their plan and where we can do changes across the system to support that. So I guess it's that organisation that's where is the most financially troubled in the system.
Yeah. I just come in at a bit wider than that, colleague. So as an NHS in Devon, we submit an operational plan every year. So at the beginning of this year, we submitted an operational plan that obviously covers off the financial requirements to deliver within our means, but also in terms of our performance in planned care and urgent care. I think picking up your point around sort of other areas of risk at this point in the year, similarly to the financial position, we know that in again, particularly at Royal Devon, that they are behind plan on their elective or planned care, and therefore we have patients waiting longer than we would want for some procedures. But again, similarly, as Kirsty set out in terms of financial recovery, we have a recovery programme which is also looking at how we can clear those people waiting the longest so that we can get back onto plan, and again working really closely with our regional colleagues around that oversight with those key providers. So I would say that's probably another area around elective and planned care that is a particular challenge for us at the moment. With other performance areas where we are delivering on plan, but for planned care that is a pressure for us that's obviously of concern.
Thank you. Councillor McGough?
Yeah, thank you very much, Chair. I agree with you, Chair. It seems absolutely dire, and unfortunately, the trust are financially, well, I'd say financially in trouble. It looks like you're trying to cut the bare bones out of everything, and that's only going to affect the residents of Devon. You already applied for the 106 funding from the planning authorities to try and bump your cash reserves up. So that's another nice little way to try and get some money from the residents of Devon. But again, Devon County Council, we get such a small amount of funding from NHS anyway. I just feel now it's going to put even more strain on the Devon residents through the council tax precept to kind of bolster up your shortfall in your funds. Again, I think you can't put a price on their life, but for residents of Devon, this is going to really put us at harm. I think there's no dig at yourselves. Please don't take this personal. It just seems to be a lot of middle management. And then when you get too much middle management, it kind of goes away from the core basis of what we're actually here for. And I think it's going to put harm to residents of Devon. It's not good. How do we solve your lack of funding? Obviously, central government. I don't think anyone takes on account that how rural we are, the actual need of our services around here. But I'm glad we got fellow colleagues here now for the social care, because I can see our council tax precept going for the roof to try and cover the shortfall of money that you obviously can't provide for the care.
So I'm not aware that we're not funding anything that you're supposed to fund. You know, I'm not sure that. So we're still honouring all of the rules on the Better Care Fund uplift and the funding that goes into that. So I don't think we've actually taken big savings measures on anything that directly impacts the council.
I can say, I believe it is going to impact the council, because the way your strategy here you're trying to push away from the direct care for the hospitals, and you're trying to put it back into the community. Therefore, the care comes back to us, and it comes a financial contribution from us, and the burden to Devon County Council, and more so the burden to the residents. You're trying to take numbers, which looks great on your side, but trying to take numbers and doing your graphs, it doesn't help the residents of Devon. So unfortunately, I look to our lead member over here. Your work's going to be even busier.
And I think we've got Tandra who might like to come in at this point. I have your hands up.
Yeah, thank you, Chair. I suppose I just wanted to make a point of clarification around the precept. So I think the general point, Councillor Gough, you're trying to make is that when the health system is under pressure, then the whole of the pressure is felt by the council as well. And so I would absolutely support that. But the precept is just targeted at adult social care in line with the government's grant conditions, so it can only be spent on adult social care. And absolutely, the Better Care Fund, we are trying to reduce costs in it as part of an agreed savings plan in partnership, but it's not being targeted for an overall reduction. We just had the uplift amounts announced for next year, but I just wanted to just address the point about the precept really and what it can be used for. The general point, I think, is that with our health partners under pressure, then everybody will be under pressure, and I would absolutely agree with that.
Thank you. And if I could just go to Donna Manson.
First, I'd just like to say to NHS colleagues, I am concerned. I'm being quite open and public about this, about the stress that you are under as colleagues. You've talked about, is this a reasonable plan to go from 213 million to 253 million? The scale of that is extraordinary. I do ask whether the point made by Councillor McGuff about delivering services in remote areas is actually recognised, and also we have our legacy issues as well. So my view is that, and having previously been part of the ICB board, that it was a high risk plan, but it was not achievable plan, and it is stressing the system. And one example of then the impacts of that stress is my Director of Finance, who raised this with me a few weeks ago, has said that our NHS age debt, which is owed to us for more than 90 days, normally runs at about £1 million, but recently it's increased to £4 million. So there's an example of how the stress in NHS is then affecting the money in Devon County Council and our cash flow and so on and so forth. But I think equally so, we spent a lot of time earlier talking about stressed families and our most vulnerable families. And I can see the impact through case level of staff in NHS provisions, phoning us to pay for things within hospital buildings. That we've never heard of that before, and escalating concerns to Tandra and myself. So I think it's important that we support our NHS colleagues by recognising I'm seeing signs of that stress, and there's no doubt in my mind, I've just given one example, there are cost shunts to our organisation as a part of that, and I think it needs to be looked at. I have discussed this extensively with the leader, and we are seeking an urgent meeting with the chair of the new Devon, Cornwall and Isles of Scilly ICB, with our cabinet leads in children and adults in that meeting, not to criticise our colleagues, but to see how we can work together in this very challenged situation. Thank you.
Thank you. Councillor Granger and then Councillor Julian, please.
Hello, thank you, Chair. I wasn't sure if I was going to, if it was going to come round to me, because I've raised my hand, I think 4 or 5 times, and I keep getting missed. So thank you for getting to me this time. I would just to add to sort of Councillor McGough's comment about NHS budgets. And I appreciate that everybody seems to think that the NHS just needs more money and funding is tight. However, I work in the NHS and I can see catastrophic levels of waste on a daily basis. I'm talking 24 members of staff on one ward for one patient, or we're paying for things like the International Nurse Scheme, where we'll be paying for the flights and rent for foreign nurses to come to the UK. And I'm not convinced that actually more money is the answer to this. I can't help but think that streamlining services is significantly better. I mean, I know of managers that spend sort of 4 hours a day in meetings where they contribute nothing, and that is a daily occurrence, 5 days a week for them. And I think if they're on £60,000 a year, could we not be utilising those assets and those people a lot more effectively? I'm sick of hearing that the NHS is tight on budgets, because actually I don't think it is. I think we're just wasting money. Thank you.
Councillor Julian.
Yeah, thank you, Chair. I think, you know, when the vulnerable people get into the hospital, you know, and they're being looked after, and then there's a chance for them to go home. The carers there only seem to be talking about where they're going to go rather than before talking about the patient. Is it possible to get home? Because don't forget, the patients, they really only want to go home. They don't want to go into care. They want to go back to where they belong. And the carers could actually look at their property, and if it just needs a little clean or something that can be like a rail that's falling off, oh, you can't go into your property, we need to, you know, it's unsafe. They're probably been like that for years, but it just needs somebody to put a screw in there to make the banistrail safe. So they could go back into their property rather than move them probably at hundreds of miles away from where they've just come out the hospital, which doesn't do them any good. And as you know, when we're all going to get old, but you need to be looked after. The vulnerability, they lose their skills very quickly if they're not put back, if they can, back into their homes so they can carry on and have the confidence. Because if you've got confidence and you still can get back home, you'll recover far quicker. And I think that's critical. If you can't, obviously you have to go in a care home, we understand that, if the complex needs are just too much. But I think we could save a lot of money here, Chair, that if you have the carer assessing and then speak to the doctors or whoever it is, and then have another assessment to move them onto their homes or wherever they've got to be, close to where they live. I think we could save a lot of money rather than just say, oh, well, another bed, let's get them out and let's get on with the next person. We're not conveyors, we're humans. We need to be, you know, looked after and cared for. And I think that is the way forward, not quick fix. And I think we could do it, Chair. What do they think, the panel up there?
So I think we would agree completely with those sentiments, Chair. And I think what I described in the opener, which is about the strategy that we built for the NHS in Devon based on the 10-year health plan, is very much about how we can support people much closer to home. But that's going to take a significant shift and change in the way that we currently commission and deliver services. So, you know, I take the point that it's not a quick fix. There's quite a lot of work to do with our providers to deliver services really differently, but we are really committed to doing that, because that's the only way that we're going to ensure for the future we have a sustainable NHS. So absolutely would agree with the sentiments, and hopefully that's what you'll see within the strategy that we've built.
Chair. Used to be years ago, we used to do all this. I see somebody's dropped the ball here because, you know, the pandemic's come along, everybody's closed ranks, everybody can't see anybody anymore. And then we sort of moved on without going back to perhaps that's how we should have done it in the first place. I think they've dropped the ball. We need to pick that up jolly quickly. We are stressed for cash and it's not running smoothly. And I think we could make it much more efficient. Thank you, Chair.
Thank you, Councillor Dawson.
I do agree that quite often being at home is best, but I think there's also a lost group here, particularly older people who are frail, are isolated, can't answer the doorbell, have somebody coming in half an hour a day, they've been discharged from hospital and they don't feel safe. I think it's great to be at home when you are safe being at home, when you feel safe being at home. And I hear quite often from residents who have been discharged because going home is best for them. And they don't feel that it was best for them because they've come home to fear and feeling like a target because they can't fully, you know, they can't go and answer a door, which means is someone more likely to come in. I think there's a whole group that's lost in this that I don't see ever mentioned actually when we talk about home is best and integrated care and everything being in the community, is those people who don't feel safe because of their illness. You know, having a falls monitor is great, so you can arrange at some point for someone to go and scoop somebody off the floor and assess their injuries, but that doesn't make them feel safe. We'll be able to find you at some point rather than I'm in hospital because at the moment I'm a high risk of falls and I have got whatever acute medical need going on. As someone who was discharged 2 hours after having a full hysterectomy, which is probably one of the worst days of my life, I can't see always that being rushed home and pushed home when you don't feel safe is the best. So I guess I'd kind of like to know what engagement is done with people who are at home, who have gone home and are potentially not feeling safe at home. I've challenged this. I've been in meetings for years with NHS England when they've said this is the best model for everybody. It doesn't fit with everybody. So what work is done around safe discharging and discharging when people have pain under control or have a plan or have backup? What work is done with people who are isolated and people who can't even answer their front doors and will be alone for 22 hours a day trying to manage their own health if they're older or struggling? What engagement is done when you come up with a, I mean, the whole plan looks lovely and shiny and you've thought about lots, that's great, but I've seen lots of these strategies pop up and I'm not sure that it actually leads to long-term change and increased health benefits to the community. So I guess that's where I'm coming from. Thank you.
Yeah, absolutely. I'm just, I don't know whether our colleague Chris Morley is here. Ah, there he is. Because I think he's far more in the know around some of the specific services in the area. So Chris, sorry to put you on the spot, but you're probably much better than I am responding.
No problem. And I'd literally just put my hand up, Libby, to respond to that
brilliant.
point.
Thank you.
I think raised is a really important point. So recognising that actually complex needs for individuals on discharge is different for each individual. I think as Libby has described around the health and care strategy, so we acknowledge that, you know, the premise of no, there's no bed like your own bed, and how we support people to live in their own community and be supported in their community and return back to their community when it's appropriate. The opportunity that we've got and the strategy describes a model aligned to national best practice around the development of integrated neighbourhood teams, is how we look much more holistically around individual needs, making sure that we're developing multidisciplinary teams that have got the right specialists to provide that support to those individuals who require it. But also recognise the strength of other assets that we have in Devon. So we've got a really rich and vibrant voluntary and community sector, how we work with them to make sure that we can support those people who might need different types of support. But equally then recognising that there will be some individuals who can't necessarily return back home straight away, how we therefore have the right kinds of settings to be able to support them in that they can continue that recovery journey. But then enable them to return back home at an appropriate point. And I think, you know, that's kind of the fundamental part of the strategy, is how we work collectively alongside yourselves, members of the public, through our engagement and working alongside Tandra and the teams from a social care perspective, to ultimately get to the point that we can support as many people as quickly as possible to get back home. And you know, I'm a strong believer that actually, if we get hospital discharge right for individuals, we all gain, not least of all the citizens of Devon who will receive the best possible support and get back home in the best possible way. And there's then a knock-on impact in terms of, from a financial perspective, it costs us less money in the short term and long term. But fundamentally, that getting those individuals and supporting them to recover and live as fulfilling lives as they can do on discharge is absolutely key.
Thank you for that. Can I just go back to the 255 million? So the books are being balanced, my understanding is, because you're getting a deficit support grant and some regional support. The RDU is struggling financially. It looked like other parts of the system were underspending, but that's earlier in the year, but that's stopped. So what I'm not clear on is how you're going to achieve that £255 million savings. You can't make the redundancies because you haven't got the resources to do that. There's reference to 486 whole-time equivalents members of staff being over planned for the month. So what I would really like to know for residents is how you're going to make that 255 million, and what does that look like in terms of changing the services, and also how are you going to do that without shunting the costs elsewhere to Devon County Council?
So we do have a financial recovery plan. At the moment, we've sort of have things mitigated down to about 25 million. As that's where our problem area is at the moment. So where they can't take the costs out for the staff, they've had to find other saving schemes to make. Some of that has been non-recurrent, which isn't ideal, but it's where you can just get one-off benefits to help you out throughout the financial year. So all of the organisations have had to make decisions on if there's any flexibility on their balance sheet that they can use to offset where they've not been able to deliver savings. But none of them have been around cost shunting. None of them have been around not delivering services, because we would do an EQIA and a proper assessment if we were going to decommission any services. So that's not what's been considered at the moment. I'm not saying we wouldn't have to get to that point, but there would have to be a proper process to do that. So it's unlikely to happen in this financial year. So it has been a case of finding other things to replace where they can't do what they originally intended, which is around the workforce reductions.
Thank you.
So a lot of the areas that they're looking at as well is there's been these we've got these productivity packs that have been provided to us, and they're based on each hospital's data, and it gives them areas where they're less productive than other hospitals that are like in their peer group. So, you know, can they improve their length of stay by doing certain things? Can they improve their theatre productivity? So there's a lot of things that they're addressing there which help get the cash out as well in terms of improving the productivity. So doing more for less. So that's been the focus as well, and a push on that side of things to improve the productivity. Because you'll see in the report the productivity improvements have not been brilliant this year, but we've now had this data pack, this information that's gone out to all of the trusts. We've asked them to review it and to take what action they can to improve the productivity. One, to recover their savings position, but two, because we want them to be the most productive they can anyway.
Thank you. Councillor Dawson, have you got?
Sorry, I just wanted to come back on the answer that I'd received. Thanks for that. I'm always a little bit dubious and fearful when we have any organisations really referring to the use of volunteers for delivering part of their vision, because we're seeing quite a huge nosedive in people taking up volunteering. We're seeing people working for longer in their lives. We're seeing dual parents working in families, which means grandparents are stepping in more when they have finally retired. We're seeing less and less volunteers, and I work with volunteers in my other life, and I see it across the board. I talk to voluntary organisations from across Devon. Everyone's reporting that it's really difficult to recruit volunteers. So I guess I'd like to know if you have some sort of magic solution, or you're hiding volunteers maybe from the rest of us, that you're going to bring out to be able to deliver this vision. But I really am quite concerned, and it was the same when South West Ambulance Trust are looking at, oh, we're just going to have 2,000 volunteers across Devon and that's going to deliver this vision. And those people aren't there unless you know something that I don't. So I'm quite happy to be educated if you have some knowledge that I don't have on that. But I think that's really concerning actually, because that you're relying on that to provide a healthy, forward thinking and safe service for Devon. And I just don't think that we can, in the current climate since COVID, rely on volunteers being there.
Can I come back on that? Okay, thanks. So just to clarify, I absolutely recognise the challenging position in terms of availability of volunteers, and just to be clear, I wasn't suggesting that was entirely our solution to hospital discharge or supporting people at home, but it's how we work collectively to understand what resources are there within the community and how we work around those communities and the population to understand what it is that they need and would benefit from, and then how we work together collectively through our respective strategies to make sure that we're growing and developing that offer. And obviously that is just one component alongside reablement workers, home care workers, nurses, and therapists, in terms of that kind of holistic approach around supporting individuals. I absolutely recognise the challenge that is the voluntary community sector's access to volunteers, and working really closely with them as we develop our integrated neighbourhood models at a local level through the voluntary community sector assembly that's in place in Devon, to make sure that we're developing those plans jointly with them that responds to the assets that are there and where the challenges are.
Thank you, Chris. Tandra.
Thank you, Chair. And I might ask, because it's easier for Amy or Sove to come in, but I just wanted to make a general point about hospital discharge and some of the comments that Councillor Julian made. So we're absolutely committed to a home first approach. But what I will accept is that the hospital discharge pathways, which we're trying to work with our NHS partners to recommission, aren't as effective as we would like them to be. And what we see from a council perspective is more older people ending up in residential care, so being unnecessarily institutionalised if we've been able to get them home at an earlier point as they were discharged from hospital. But all of the things that you're talking about in terms of does it need a house need clean, or does it need a small piece of equipment? We've got an amazing independent living centre. We've got the community equipment store contract, which sits in the Better Care Fund, which is overspending, I'm going to say, and 80% of the prescribers are from our NHS partners, but mostly it's down to helping people out of hospital. So we are doing everything we can as a system to help people get home as a first priority and be safe whilst they, when they're there. So sometimes there are other complicating issues that hinder that. And I suppose the other thing I'd just like to say is we whilst the BCF was what it is, and we will work through the uplift conversations, I think what you're referring to is in our benchmarking, which we shared recently, we were seen as, I think, nationally below the national average of NHS funding, and regionally we were at a lower end. I think we'd want to get underneath that to understand why are we different, because we all measure things in different ways, so it's quite hard. But absolutely we are feeling that pressure as an organisation. So I think if I look at what our care packages look like now and the ones that the people that we are supporting, what I see is an increase in complexity, and things that we might have thought that would be NHS funded are now local authority funded. But, I think we probably want to work as a system to understand whether that's, how much of that is NHS and how much of it is local authority and how much of it is as a product of an ageing population. But I think my colleagues in the room, it's probably easier for them to come in.
Thank you, Tandra. Donna.
Yeah, I think it would be helpful to, in advance of the meeting, that the leader and the cabinet leads are seeking the chair of the board, because I think that's right and proper. It's important. I'm quite happy to set out some of the cost shunt issues. I've given one example to date, but I also know that over £1 million Ascend invoices have not been funded by the NHS. And I also know that we have concerns across our children's services in Devon of, Tandra's given some adult social care examples, but in these really complex cases, we are not getting the funding for the health piece and EHCP. So I think for transparency, we should set those out. And I know that, it's not just a Devon issue, it is across our children's services in the Southwest. And I say that in support of, trying to work together as a system, but equally so, members need the transparency of costs that Devon County Council is funding that we were not funding previously, or other parts of England and other systems in England are not funding from the county council budgets.
Thank you. I think if we could probably come to an end on this agenda item. I mean, I feel that it's quite a precarious financial situation, and I do think it's important to have a further update. So because it seems to be shifting quite quickly, and I'm concerned that there may be further deterioration. I know now that it sounds as though the operational risk may have subsided because there's some cash available, but I think the underlying crisis is still there, and I think it potentially is very, very significant for it is very, very significant for our residents. So I would like to call our NHS colleagues back again for a further update in our next meeting. I'd like to understand more about the financial position of the RDU, particularly because that seems to be really struggling financially. So I'd like to thank our NHS colleagues for coming here today, but ask that you come back again. And I'd also like to be clear in our update, if we can be clear, if it's possible to articulate from our adult social care perspective, how we're seeing those financial pressures within the NHS translate into pressures in our services. Certainly from an adult perspective, and I mean, I don't know whether it's very difficult. We don't want to be siloed and have like, you know, this is adults and this is children's, but we're seeing this NHS, this is the adult health and adult care, but we're seeing that shunt across our services. So I'd like to understand holistically what this means for Devon County Council, what it means for our residents who are paying their council tax to us, and is it being spent through Devon County Council, or is it being requested to be spent elsewhere? So I think we need to have a look at that holistically.
I think it's important to say, particularly in the SEND area, that for an adult social care, that those costs in SEND and making sure that children and young people get the right support, that then transfers into working age adults. And actually, when you look at the financial challenge, it's more in the working age adults population that we're seeing that increase in complexity. And I think it's just very important that the H and the EHCP is funded properly.
Thank you, and I think we need to see that clearly as a committee, what's happening. So I'd like to, if that's okay with the committee, invite our NH colleagues to update us, to include details from our Devon County perspective, what's happening, and discuss this again in our next meeting so that we have a further update.
I think that's a brilliant idea, Chair. And I think, you know, we need to keep the lid on it and see if we can collate all this information, and then we can then ask our NHS colleagues how it's progressing. Good, Chair. Thank you.
So if we could move to a vote on that proposal. Thank you very much, members. Thank you very much to our NHS colleagues for joining us today, and thank you for your report as well. Thank you.
Thank you.
Thank you.
Okay, so if we could go, sorry, back on the agenda, back to item in-year briefing. So this is the in-year briefing, and it includes the performance dashboard on adult social care, agenda item 9. And I don't know whether Cabinet Member Richard Keeling, Councillor Richard Keeling, would like to introduce the item.
Thank you, Chair. So this report provides an overview of working with you over the last 6 months. If I can talk to the key successes that the report highlights, is committee engagement, and thank you for that. Strong collaboration since July 2025, which was your first meeting. You have influenced Cabinet to embed service user voice and approve improvement initiatives, and I'm talking about the Newton Partnership and the Standing Overview Group. Workflow and waiting times, reduced care act assessment, waiting lists, improved timelines, better communication with service users, investment in new care management IT system, commissioning, market position statement published, and information contract revisions, monitoring out of area placements, safeguarding, Devon Safeguarding Adult Services, waiting list halved since July 2025, improvement timelines and inquiries. And if I can say that strategic priorities are covered in 6.1 to 6.6 of the report on pages 47 to 48, and the appendix A and B are there for your information. Chair, as always, we are here to answer any questions.
Thank you very much. Councillors. Councillor Rogers.
We just heard from the NHS and we're doing Newton, which I support because that'll save money. Why can't we insist the NHS do their version of Newton to make it better for people of Devon?
Solveig.
So we can certainly encourage our partners to adopt the same kind of approaches, but we can't insist that they invest money in this kind of approach. What we can do and what we are doing is identifying priorities for the people we support, and those will naturally be overlapping with some of the support that they get from the NHS. So we've heard just now about getting people out of hospital discharge. That's our top priority for our work with our Newton partners. Indeed, they're in today running a workshop with colleagues, understanding some of the support that we put in place for people to get them out of hospital and stop them going into hospital in the first place. So as part of that hospital discharge approach, that will have our colleagues from our acute hospitals and also from the NHS Devon, who we've just heard from, all coming together, all supportive of understanding how we can get things right, change those pathways and make sure that we get people out of hospital safely and in the right place as quickly as possible. At the moment, the processes feel a bit cumbersome and a bit clunky, and we haven't really got but we aren't assured that everybody's going to the right place straight away. That piece of work Newton are doing this month will help us get that right.
It's not working with the NHS because they're failing. So we're working our socks off to get our bit right, but the NHS partners are not doing their bit.
Tandra?
So I just want to say that is a good question, Councillor Rogers. So I know that the NHS are very interested in Newton, and there will be a mutual benefit in the HD work that we do. We've been focusing on signing up with Newton ourselves, going through our own processes. As Solveig's just outlined, we can't insist that they join us, but what I would say, in the couple of conversations I've had, they're very interested. So there might be an opportunity for them to join in at a further point. I would also highlight it's much more complex. So we're focusing at it from a Devon County Council perspective and just one directorate. Whereas when we're talking about the ICB, it's many different organisations across the community and acute, mental health, physical health, all ages. So I think they probably do need some additional support, but it's more complex than perhaps where we're focusing on one aspect of the work the council does.
Any other? Councillor Julian.
Yes, I appreciate that, we're trying to move them out of the hospital, but I think central government has also mentioned many times since they've been in power that they would want the community hospitals to be a stepping stone to get from the main hospital, so there's more room for other people to get into their beds. Not into their beds, I do forget, but I mean the beds available. But move into the cottage hospitals just for that extra, if they're not quite fit enough to go wherever they have to go, like home or into care. Just that little stepping stone would make a hell of a difference. We have the community hospitals, and they're all desperate to use them. I mean, they're there, and it's been fantastic to encourage, especially in North Devon, where we do need this very much so because we're so sparse. So if we could encourage them to use that, I mean, the government's already suggested that we should use them, and I think we should take that mantle. Thank you.
Chris, thank you. Councillor Chris.
Thank you. So a couple of points. So certainly in terms of that last point, really good point around use of our community hospital beds, and they're all used for slightly different purposes across the wider Devon footprint. And as I mentioned around actually our joint collective work around a focus on hospital discharge, the role those beds play is absolutely essential. And we've been having some conversation with NHS England about how they support us in understanding the patient groups that are currently utilising them and making sure that's optimised. And it all comes back to, as I said earlier, around that integrated model, jointly working with social care, that we can make sure we've got the right pathways for people coming out of hospital. I think also just respond to the points about Newton. I think as Tandra Solvay said, we're absolutely committed and connected to those work programmes and exploring the opportunities for us to align our work and activity, and those conversations continue.
Thank you. Councillor Dawson.
Could I just ask our team what they see as, how they see the winter going with winter pressures and things like that? So I'm really happy with this update and how things are going, looking at the risks and the work that's being done. I guess I just wonder, we're now in December, so winter pressures start to hit, and that obviously has a knock-on effect of service delivery all round. What are the fears at the moment with the team, or how do you feel winter might go?
Thank you. So I think we all have pressures, and sometimes there's a bit about, is it really winter pressures these days? Because we tend to see it coming in earlier through the year as well. And actually this year we've seen a challenge in the month of September, coming into the kind of cold and flu season already. So I think we are anticipating that this winter is a particularly challenged one. I know already this morning colleagues across health and social care have been coming together again, particularly with RDHU being in a kind of critical situation in terms of the hospital discharge and flow today. So we're continually working together around how we can support hospital system pressures and the winter. I think the bit that is really important for us as well is about that preventative bit in the community. So trying to make sure that we give as much kind of support to our provider market that are out there visiting people in their homes regularly. So making sure things like heating's on, people are well, people are fed, kind of looking at that kind of wider support in the community through the social care provisions we have. So I think all winters are challenging. I think this one is already starting to feel like it's a challenge, but we do come together really well in those kind of particular challenging moments to really think about what we can all do as a system to support people in the communities, and where is appropriate, kind of getting them back home. I think staff wellbeing and resilience is also really important. So kind of making sure that we've got the right staffing levels and that we can, facilitate people taking breaks where needed to, and kind of coming together and sharing, and that kind of peer support and wellbeing for our staff, and monitoring our own kind of, absences, etc. is kind of all the things we usually do.
Thank you. If I could just ask a question, please. So first of all, I'd like to really welcome the performance dashboard. I'm really pleased to see that coming forward, and it shows a lot of good work, and I think it shows a lot of progress, but we do still have delays. So I'm thinking in particular about the median wait for reviews, 195 days. The DOL's median wait is 274 days. And we don't have any equality analysis of typically who's waiting longest within our communities and who's experiencing worse outcomes. Is that something that I know that we've touched on the difficulties with collecting equality data earlier, but do we have a sense of who's experiencing the longest waits? Is that something that's possible to try and understand?
I think it's who's experiencing the longest delays are the people that have been triaged to in terms of the risks in the community. So I think that the way that we are looking at the work and how we profile, how we have a limited workforce, and how we kind of redirect for the priorities is predominantly based on that risk factor, as opposed to a particular kind of individual or type. So I'm not sure that we can triangulate that information against the kind of the profile. I think the way that we manage the risk is all about ensuring we're getting to those most in need and our most vulnerable members of the community. Inherently, there may be pockets where we know who our most vulnerable kind of members of the community are, but in terms of waiting list triage, the priority is really about focusing on risk.
Okay, if I could just ask a follow-up. Do we have any sense of harm that comes to any harm that comes to our residents from being on any of these in our waiting lists?
So I think a big part of the Waiting Well programme that we have been focused on really ensures that we are regularly keeping in contact with individuals. We are talking to people about their kind of experience. We don't want anybody to wait on waiting lists, but we know it is a challenge for us at the moment. And so trying to map that person's experience as well. So if there were concerns, then again, we do re-triage, reprioritise and kind of refocus the attention on those most in need. If something does come in, obviously, and it links into a safeguarding responsibility, then we're able to triangulate that back through the safeguarding approaches that we have as well. So I think we've got a fairly good handle on the individuals who are waiting within our system. We are keeping in regular kind of contact and communication with those individuals too. Inherently, anybody needing to wait, whether it's on a social care or health list for an operation or appointment, etc., or for our assessments, that's not going to be their optimum well-being. Their optimum well-being is going to be when they're getting the services that they've requested. But I think that the Waiting Well approach we've adopted across the last kind of 12 months to improve that enables us to have quite a good handle on who's waiting, how we're triaging that, how we prioritise it, and then how we keep in contact with them during that wait.
Thank you, Tandra.
I think Amy may have said everything that I was going to. So we have the Waiting Well and we risk triage. So in terms of making sure people are safe, that is a constant process, so that somebody who is really in need of support, we're getting to them at the earliest point. And if they are waiting, as Amy says, we're checking in on them to make sure they're okay.
Thank you. Can I just ask one more question, please? And that's about the DOLS applications. And so it says that in 2023-24, Devon County Council had the 4th highest proportion of applications from acute hospitals in the country. Why do you think, could you explain why you think that is, please, and what that means for our services? Thank you.
So if I come in on that, and maybe Amy wants to come in after. So I don't know whether you recall, but originally there was a consultation about deprivation of liberty safeguards, and there was going to a suggestion that they would review the process and bring in LPS, liberty protection safeguards. At that point, there was a view that responsibility for different aspects of it would be more shared. So it wouldn't just rest with the local authority. And so some hospitals, so RDU, for example, put some investment in a team. So I think we're seeing the product of the investment. So they're identifying people quite rightly who should be identified for a DOL. And I think that's sort of predominantly why we've seen such a spike in demand that has continued, because they're continue to do that work. It is the right thing to do, and it probably should have been happening before, but what we're seeing is an increase in the numbers of short-term requests for a DOL.
Thank you. Does anybody else want to ask anything or comment? I mean, I would certainly welcome kind of the continued discussion and a masterclass around the data, and to explore that further. I mean, it's difficult, isn't it, in a kind of formal committee setting to kind of really drill down into too much of the individual data. But Councillor Rogers.
Chair, can I request we have some information post-Christmas as to how the Christmas period has gone within Devon and any impact it's had on the various challenges we face?
Could I suggest winter is longer than Christmas? So I think we'll be experiencing these pressures, although my colleagues may challenge me, up to February. So very happy to come back and say, but I think if we just did it after Christmas, it would be a very short period of time, and we're likely to experience winter pressures for longer.
Yeah, I appreciate that. Thank you. That'd be a good call.
Sorry. So I think also with bringing in Newton, I think it's really important that we continue to look at the performance data to, so we're going to have a standing overview group. We're going to have a masterclass, aren't we, Tandra, around the performance data following on from this meeting. So I think that probably unless I'm happy to put forward, I think, those recommendations and as drafted. And obviously we'll ask for Stuart to have the information that he requests. And unless anybody has any further specific comments, that we continue our discussions around the performance data in our masterclass. Shall I make that proposal? So we propose as the recommendations as drafted. Everybody in support? Thank you very much. Okay, we're getting there. So I think we're now on item 10. Steve Brown, please. Oh, sorry, Councillor Cottle-Hunkin, who's joined us online to present the in-year briefing for public health. Thank you.
Can you hear me okay?
Yes, thank you.
Chair, members, I'm pleased to present this mid-year review for the Public Health and Communities Directorate. While the report covers the full breadth of the Directorate's work, including communities and trading standards, I recognise that the focus of this scrutiny committee is primarily on public health, and I will therefore concentrate on this section in my introduction. The report highlights the publication of the Director of Public Health Annual Report, which this year focuses on the harm caused by alcohol. We know that in Devon today, too many lives are being cut short every year due to alcohol-related harm. The report presents the latest data, research and evidence on the impact alcohol has on individuals, families and communities, and sets out actions we should consider to reduce this harm. The scale of the challenge is clear. Alcohol-specific mortality has risen by 18.5% since 2006, reaching 10.93 deaths per 100,000 in 2023. Under 75 mortality from alcoholic liver disease has increased by 41.9% since 2001. Alcohol-related hospital admissions have grown by 46% since 2016-17, with admissions for liver disease up 70%. Admission rates for alcohol-specific conditions in under 18s remain nearly double the national average. Alongside this, the briefing demonstrates the breadth of work undertaken by the public health team this year, emphasising the importance of good data and intelligence to enable evidence-based decisions. Our programmes aim to reduce premature deaths and increase healthy life expectancy through initiatives such as tobacco control, with smoking remaining the single largest cause of preventable illness and premature death. Delivery of over 20,500 NHS health checks, including outreach to rural and coastal communities, expansion of blood pressure checks and oral health initiatives like the Big Brush Club, now the largest supervised toothbrushing scheme in England. We are also supporting children to have the best start in life through the excellent work of the Public Health Nursing Service, which is exceeding all national targets set by central government. Crucially, we are working with partners to tackle the rise in drug-related deaths and suicides in Devon. Demand for key public health services continues to rise, including sexual health and drug and alcohol treatment, as well as support for people seeking to quit smoking. Driving down smoking rates remains a key priority for reducing health inequalities. Beyond public health, our communities work is addressing the cost of living crisis with £44 million in household support funds distributed since 2021 and the reopening of the Growing Communities Fund to support local projects tackling food and fuel poverty, loneliness and isolation. Our library service continues to innovate, providing much more than books, and there is great work happening together with public health. This year saw the launch of the blood pressure monitor loans available from all 50 libraries in Devon. Finally, I would like to take this opportunity to thank the public health team for their hard work and dedication this year in improving health outcomes for Devon residents. Their efforts are making a real difference in tackling inequalities, supporting independence and building stronger, safer communities. Thank you.
Thank you very much. If we could go to questions on the report. Councillor Julian.
Yes, it's quite a wide range of a report, really. I understand from there's just being a report that's just come out that vaping seems to be bigger than smoking now, and also there's been quite a report that people that have had lung problems, where it's burning their lungs from inhaling these special chemicals, which is now sort of accelerating rather smoking. I don't smoke myself, so I'm not saying we're protecting the smokers, but how it's turned, that's what I'm getting at, and how it's turned. So we need to address that rather than have a broad statement that, you know, smoking, but we haven't brought up the vaping, which is a big concern. And the other thing is about, yes, isolation, deaths, you know, people lonely, especially in farming, rural communities. They need to be taken into account. But it is a big, broad, Chair, report, but there are concerns there that I think need to be addressed more for Devon than obviously across the country, but we're talking about Devon, because the vaping is out of control now. So I think we do need that if we can in the communities, and also selling them illegally seems to be quite something now at the moment. So we need to address that as well. Thank you, Chair.
Steve, would you like to?
Thank you, Councillor Julian. Yes, so just on the vaping bit, to be really clear, we've been working really hard to switch and convert smokers to vapers, because we know, and the evidence is really clear, in the short and medium term, I don't know about the long term, vaping is far less risky than smoking. That's government fact. Chief Medical Officer, no disputing that. The long-term consequence, so 20 or 30 years down the road, we do not have the evidence in there. So as we convert people from smokers to vapers, you are going to see a rise in the number of people vaping and a reduction in the number of people smoking, which we are seeing. So put it into context, we're currently in Devon, about 10% of the population smoke. You go back to when I was a lad in the 70s, it was closer to 50%. And we're seeing a reduction in deaths caused by smoking. The biggest issue for me is, and of course, when you get to vaping, we want you to stop vaping as well. That's a journey to stop vaping, is those who aren't currently smoking, taking up vaping. So particularly amongst the younger age group, the children who never smoked and take up vaping. And we are seeing harm. Vaping causes you harm. What I'm saying is it doesn't cause as much harm as smoking in the short and medium term. So we are doing a lot to address that. How we work with schools and education, and you know, vaping is nicotine containing, so it becomes addictive. So we are seeing 13, 14, 15-year-olds who are addicted to vaping, and how we support them to come off that. You make a really good point around illicit tobacco and illicit vapes as well. So in the report, there's a nod to training standards, and apologies for the length of the report. I try and do one report to cover the whole of the directorate, recognising that the communities and training standards is generally worked through the other scrutiny committees in CARES, for example. So forgive me for the length of it, but we are doing a lot around training standards. So you will see in the news on a weekly basis closing down of very sophisticated shops selling illicit tobacco and illicit vapes as well. Unfortunately, as soon as they close down, they literally pop up again. So it is a hugely challenging, and there are, you know, hopefully new legislations with the smoking bill coming in, which would give us some enhanced powers to tackle that. Thank you.
Thank you, Chair. It's just that I've spoken to quite a number of youngsters. I go to some youth centres and talk about, now I'm in the capacity of the foster care champion thing, but I go to all these other things, the teenagers and the ones that are leaving school. And I've spoken to them about vaping, and they do say that they've vaped, and their problem they've got is that they can't exercise. They're more asthmatic, and they're sort of, you know, where it is damaging, and they've admitted it is damaging, and some of them had some severe consequences and been sent to hospital over it. So even though I understand where you are with smoking, and quite agree with what you're saying, but we mustn't poo-poo, and I don't mean that horribly, that vaping is, and they have some evidence, it is burning their lungs. And once you stain their lungs, you know, it's not good. So I feel that we need to be pushing this harder, that because there's more chemicals, Chair, in these vapes, and they're putting more and more, you know, things that they like to taste in it, but it's this waft going into their lungs and then coughing back out. So I'd like you to be, you know, more assertive on that and trying to get that message over. Thank you.
Just to really come back, so for the avoidance of doubt, vaping, there are risks associated with vaping, and we're seeing across the country increased number of children, generally children, who've never smoked, being hospitalised and having caused damage to them. So for the avoidance of doubt, vaping is risky. It is less risky than smoking and that's imperial data from eminent research that is less harmful in the short and medium term. I can't think for the future, but it is. And I say this, you know, as somebody who's had family die from smoking, and I tried to convince them to take up vaping and they wouldn't. So avoidance of doubt, fresh air is best. If you don't smoke, don't vape. If you smoke, vaping is better than smoking.
Thank you, Steve. I've just got a couple of questions, and that is around, the first one is around the quite shocking alcohol related figures. So they're all quite shocking, and particularly the admission for alcoholic liver disease has surged by 70% since 2016-17. So your annual report has got 9 specific recommendations to help tackle alcohol harm within Devon. How are you going to measure, and what are you going to do to evaluate the effectiveness of your recommendations? Please.
Thank you. Yeah, some will be more easier to measure than others. So you're right, and it's a really interesting pattern of drinking in England at the moment. It does vary across generations. So what we're seeing at the moment is a reduction in young adults, so the 18 to 34. There's a decline in alcohol consumption, but what we're seeing conversely to that is I say this as I'm in that group nearly. The older adults, 55 plus, we're seeing an increase in alcohol consumption. And our concern around that is not only the increase in hospitalisation, we've heard about the challenges we have in our NHS system, but also in terms of the older adults in Devon. So we're going to be disproportionately impacted upon it. There's also a growing pattern for the under 18s, and Councillor Cole-Hunton alluded to, we have twice the rate of under 18s being admitted to hospital due to alcohol, and that's in girls more than boys. So my recommendations are multifaceted. It's not an easy thing to turn the tide. Some of them are national. So, you know, government failed in its statement to introduce minimum unit pricing in this country. It did go in Scotland. Death rates reduced by 13%. So one of the recommendations is explicitly lobbying the Chief Medical Officer, which I do and we do, and I know he is lobbying central government around some of that policy. Interestingly, we had new alcohol guidance produced last Friday from the Department of Health and Social Care, so we'll be looking at that. But ultimately, in terms of good outcomes, there'll be a number of things. One would be numbers of people in treatment and how we support them. So investment into our drug and alcohol services, taking into consideration the new alcohol guidance, which literally came out on Friday, so we haven't had time to dissect all those. I think there is some evidence around some of the trend data we're looking at. So some of that will take time to play through, things like liver disease reductions in the number of harm caused by alcohol. But also we see alcohol hit other elements of society. So in the report, it alludes to things like domestic violence, sexual violence, antisocial behaviour, number of days lost at work, road traffic collisions. So those metrics will be looked at. As with many kind of public health interventions, correlation and causation is often difficult to show. What I will do know is all those interventions, so access to good treatment services, looking at legislation, taxation, looking at advertising, and as we approach Christmas, it's not dawned on any of you, I don't think, the advertising we put out there for alcohol. And I cast your minds back to when many of us in this room were children, and those alcohol advertising today were no different than the smoking advertising when we were kids. And we now frown upon that. The idea of somebody publicising smoking on our TVs would be absolutely frowned upon, but we don't do that for alcohol. So a number of different measures will have to be looked at. I think explicitly for us, having a robust strategy and action plan, which we'll be implementing, looking at additional investment into drug and alcohol treatment services, because we are seeing a rise in treatments, and be able to measure that. Some of them will not be quick, though.
Thank you very much. And I've just got one very quick question. That's like, can you reassure me and the committee, so with all the public health data that is published, how are you using the outputs from it to inform as cabinet and service directors to shape your decision making?
Thank you, Chair. Yeah, and hopefully you will see we nodded to a number of dashboards and needs assessments, and I would urge members in their own time to get a cup of tea and look through some of that those dashboards. So we spoke briefly about it earlier. We need to make decisions based on the evidence, not hunches, not what we think, not what someone down the pub told us to do. We need to have the evidence, and what we do in public health is produce some of that evidence, and that is to support our colleagues, whether it's in adult social care, children's, to make informed decisions. So point to a number of different examples where in my own area, for example, the work we've done around understanding the health needs around sexual health, that absolutely drives our commissioning decisions. So our strategy, our service specification, how we go out and procure that service, what service we need to procure, is based on that data and those evidence. Another very brief example, and I use this purposefully, but if you look at the data on the dashboard around, Councillor Julia mentioned earlier around social isolation, rurality, deprivation. Again, our dashboard is there to help us create a narrative as an authority about how our rural areas and our coastal areas, we need to be viewed upon differently around some of our indices of multiple deprivation. So Cabinet Member Councillor Cotton Hutton and I have penned a number of letters which have gone to central government, really highlighting from the data what life is like in Devon around deprivation, because often it goes unnoticed by central government because the measures they use aren't necessarily the measures which we would recognise, like rural isolation and coastal isolation and our ageing population. Well, so a couple of examples there of a service level one, but also how we use it as a broader narrative for influencing the government, I think.
Thank you. Any further questions or comments? Councillor Rogers.
Thank you, Chair. I've got a couple of questions. So we don't have banks anymore. People dispose of cash through the post office, and certainly in South Devon, there's anecdotal information that county lines are coming into Devon, into their post office, and depositing illicit funds through their banks. I've got cases at the moment where there's several bank accounts used, and I'm certainly working with the police in particular, because we have to recognise that substance abuse is growing in rural communities. In terms of alcohol abuse, Challenge 25 is a great initiative, and I've witnessed retailers ignoring Challenge 25. You're down to the person serving the individual and seeing if it's a reasonable, one, if they're of age to buy alcohol, and two, if they're buying a reasonable amount of alcohol for personal use. I think, can we do anything with Challenge 25? And on vaping, there's been incidents where people have put vaping cartridges into the rubbish. There was an incident extra a couple of weeks ago where the vehicle caught fire, and those cartridges are lithium batteries and are just going to catch fire. I think working with all the districts in Devon to try and tackle vaping disposal, because that's the way it's going. we have to think about how we're going to tackle the fire risk of vaping through lithium battery vapes.
Just thank you, Councillor Rogers. So a couple of things. The kind of challenging of Challenge 25, or indeed let's challenge around purchasing of vaping and vapes and tobacco as well. So through training standards, we do test purchasing. So we work with colleagues, so people who are, for example, over 16 but look under 16. They put them through and try and buy alcohol, indeed cigarettes, and they are challenged, and prosecutions can take place from that. So we do that. The battery ones are really interesting because what we're finding, as well as the, if you like, the legitimate vapes, which are battery operated, as we know, and the disposal of those should be to like any other battery. It's even worse when they are illicit or illegal vapes, because they don't know where they come from. The risk of fire is even increased. So again, tackling the illicit vaping industry in Devon to try and get those off our streets to reduce the potential harm is vital. And again, encouraging people to dispose of their vapes is really important. The government's, through their tobacco bill, is banning single-use vapes. So it's not necessarily just single use, but hopefully part of that policy is to reduce the number of vapes which we're seeing on our streets. And I'll just finalise the point of that because it gets even worse. When you look at illicit vapes, what's in them is not necessarily what it says on the packet. So we have seen examples of drugs in vapes seized from children in Devon, and that's no different to the rest of the country. So driving down the illicit, in this case vapes, but also tobacco, is really, really important.
Thank you very much. So
thank you. Just quickly, we've talked about, Councillor Cottle-Hunkin talked about the damage being done in Devon with alcohol. I'm just wondering, is there a place, or have the public health team already approached government about the new licensing agreements that they're trying to bring through, where pubs can open for longer and have less conditions put in place? If you feel that would actually, if that's going to negatively impact Devon with the damage being done with alcohol, please.
Thank you. Really good question. And yeah, we put a very robust response back to the national consultation on licensing submitted. My fear is it will increase accessibility to alcohol, and therefore it's likely to increase alcohol harm. So as a statutory officer, Director of Public Health, in my name, we put through a very, very robust response. Whether anyone listens or not, and we always have this conflict, and I hear this very regularly around smoking about, yes, Steve, but we get all this taxation from it and it drives the economy. Look at the data. Whatever money you make from the tobacco, either tobacco or alcohol taxation, is dwarfed by the amount of money it costs society. And so, yes, a very thorough response was put into central government. Thank you.
thank you. So thank you very much, Steve. Thank you very much, Councillor Cottle-Hunkin. So I think if we don't have any further comments, we can just note and we'll welcome and note the report, and then move on to our final item. Is that okay? I don't think we need to vote, do we? No. Okay. So we've the final. Well, I guess we've got the work programme, but before that, we've got the final report, which is a composite report, which we've always traditionally had as a committee. So it's produced by our adult care team as well as our health colleagues. It's usually a brief report with individual items, and I think this is the first time we've had it in this council term. So Councillor Keeling, would you like to present it?
Thank you, Chair, and I promise to be very swift and quick. So just to highlight, it's a general update paper. So straight in with the CQC, inspection completed, took place over 3 weeks, September to October, included on-site visits, process went very smoothly. with positive feedback from inspectors. Final report expected in 2026, early as possible, please. Adult social care, fair pay. The national consultation on adult social care fair pay agreement has started, and both myself and the chair listened to the minister who spoke in support of the recent Children and Adult Social Care Conference, which we both attended. New care home contract and fee model. The new care home contract and fee model is in place. At our recent visit, the chair and this committee and myself was at our D&E last Monday, and we spoke with the discharge team, where I was asked a question on what was the uptake on that, and I said it was 65%. I can now share with this committee, just moments ago, I've been informed it's 80%. So I'm sure that team will be happy with that. Also, an update from the Devon Mental Health Alliance. I have spoken with some members here and colleagues in the Bideford area about the Link Centre there that has an issue with their boiler. And so, as you're aware, Devon County Council fund Devon Mental Health Alliance to run drop-in centres at this centre 3 times a week, a service formerly known as the Devon Partnership Trust. We will need to relocate that service while the council looks at what needs to be done to replace the boiler. So Devon County Council Estates team are liaising with the DMHA to arrange a temporary location at the Bideford Family Centre, which is half a mile away. I understand the boiler is working intermittently, so the building has not been closed yet, but will need to be soon. Estate colleagues advise they aim to make the move over Christmas if the boiler holds out and the service closes over Christmas. I've been assured that the DMHA will support people and manage it sensitively. And if I have any further information, as I spoke to members of this committee and those that are affected in their areas, I will pass it on as soon as possible. I know this is operational and normally wouldn't be shared, but I wanted to share it to assure people that we are on top of this. If I can then, for the next part of this report, hand over to Councillor Cotler-Hunkin. If not, I'm quite happy to talk to it.
Please continue.
Sorry?
I think she's gone.
Sure. Okay. Sure. So the Devon County Council Public Health update. I thank Steve Brown, Director of Public Health and Communities. So I'll just quickly go through that. So the Joint Health and Wellbeing Strategy, Draft Strategy 2026 presents on the 23rd of October 25. Consultation open till 4th of December, which is this week. Emerging priorities, mental health, best start in life, housing in rural areas, and access to services. Next steps, action plan and outcome scorecard to follow in 2026. The public health grant allocated announced with local authority settlement. So that includes drug and alcohol treatment and recovery improvement grant and smoke-free generation grants. So the progress on that was 3,404 quit attempts achieved to June 2025, close to a trajectory and just short of 657 on that. NHS Devon update, ICB reorganisation, new cluster approved, Devon, Cornwall, Isle of Scilly. Parts of the national reduction is from 42 ICBs to 26 clusters. Formal merger expected around April 2026 or 27, as you saw. Voluntary redundancy scheme launched November 2025, restructuring to complete this financial year. Devon Health and Care Strategy approved 16th of October 2025, phased implementation underway, focused on internal awareness, partners and public engagement. Cardiology, draft case for change, identified changes not closures, aim sustainable, equitable pathways meeting future demand, pre-engagement likely around January 2026, and current working, improving elective referrals to treatment waiting times. I hand over to Steve Brown if he would like to add anything to that and answer any questions from both of us. Sorry for the quick run through.
No, that's great. Thank you.
I know
Normally, yeah,
time
normally, Chris Morley, I think, would be here for the from the ICB, but I think he's had to go. So I don't know whether any members have any comments or questions, or we just note. Okay, Stuart, Councillor Rogers.
Residents are still, thank you for the update, Cabinet Member. Residents are still concerned about Torbay and the perception that Torbay Cardiology is going to be relocated to Exeter. What can we do to reassure those residents that we're on the case to make sure it's being managed?
We don't have anybody from the NHS here, so I don't think any of our officers can probably answer that. But I would say that we just need to be really clear when the case for change comes through, because I think we're expecting that, aren't we, towards the end of January 2026. So I think at that point we ensure that a report comes to committee and we scrutinise it. Thank you. So I think if nobody has any questions or comments, we can just note that. Thank you very much. And then the final item is the work programme. That's evolving, isn't it? So if anybody has any specific comments, they're welcome to make it now or to me outside the meeting. No. So I said, Councillor Dawson, would you like to give an update? Yes, please.
Thank you. I'm so sorry.
Don't worry.
You ran out. I've made some notes actually. Can't find them. We are looking at meeting. We had one meeting that had to be delayed to get all the champions together to talk about what we're going to do across the council. We are looking at putting together a project for International Women's Day and something that can be used by the council about that sort of commitment towards domestic violence in particular. And I had sought out a meeting with Police and Crime Commissioner to talk about lived experience. That was not forthcoming, but I'm working on a meeting with someone from her office potentially, just to talk about how the agendas and the sort of structure, the way that the police work with victims and things like that, and how that's marrying up with what councillors are seeing in the community really. So that's that currently, but all the champions will be meeting up. And as I say, we met up yesterday to talk about doing a project together with officers as well. That's it for the moment, but I hope something more exciting next time.
Thank you very much, Councillor Dawson. So then we've got the information that was previously circulated, and I think that's everything. So I'd like to thank everybody for attending today, for everybody's contributions, members and officers. Thank you very much. I shall close the meeting.